Hi, everyone. A very good morning to all of you. So, welcome to the rapid revision session of pharmacology. I'm sure you guys must be waiting for this with a total feeling of forgetfulness that I'm not able to remember many of the things. Of course, it happens because I always used to tell you during the classes that this is a very connected subject, right? You have to have a basic knowledge of many subjects to understand this. So now that you're all completed all the 19 subjects, maybe you have a different take on the subject after this revision. And unfortunately, the thing is that whether we like this or not, it is a very high yield subject. You can expect somewhere between 20 to 25 questions on an average from this subject, right? So we got to study. And let us, you know, make an oath to ourselves that instead of just saying, making an excuse that I can't remember the names of drugs or this subject is not for me, and leaving it completely. And maybe by hook or crook, you get like 4 or 5 marks in the exam by fluke. Rather than that, our focus should be, let's say I'm getting 25 questions. I should be in a position to score at least 15, right? I'm saying worse come worse. Like if we hate this subject also, 15 is the score I need from this. And you know the value of one mark in your exam where it can take you. So I'm simply saying that once you do this rapid revision, understand the word rapid, please. I cannot get into every minuscule detail of this. This is not a main class right now. Example, I'm not going to discuss the roots like what is intramuscular, what is IV, etc. All those things we did in the classes back then. Those are the basics. Now I'm assuming that are the things that you should know. Okay, I'll be giving you the concepts, the brush up of what that chapter is about. Next, tell you some important drugs. You need to go through those things. Next, make sure after this, you do the 25 important question videos at 2x speed. Okay. So if you do that, once you have already studied this content, then you know this is where the questions are coming from. That's where you'll be in a good position. Once a decent confidence come, then you will be able to do well. Okay, confidence is also the key at this point of time, especially when all the classes gets done. What happens is we are sitting with a pile of books next to us, and that gives us that anxiety. How the hell am I going to remember this much? Because remembrance is the key. But let me tell you all one simple thing. Doctors, the problem is that we are all saying that I don't remember when you have over expectation with yourself. You know what happens when you say, sir, I don't remember? What your thought process mostly is that if somebody asks you a random question, just verbally, you should be able to answer it verbally like that. If you're able to answer like that, then only you assume that you know some topic. It's not like that, doctors. Like even in the real life, we are not going to say everything verbally to everybody and go, right? But back in our head, there is the knowledge that is present. Okay. Your exam is not a Viva exam. So why are you over expecting that verbally you have to say? See, verbally, the things to be recalled in a second can only happen if you have revised 6, 7 times at least. And I don't think for most people, especially people taking this exam for the first time, you have that much time. Okay. When you do like 2, 3 revisions, I'm sure the other faculties have already told you that how you'll be doing those 2, 3, revisions during this session. Once you have done that within this 40, 50 days, whatever is remaining, like 2, 3 revisions of quick, multiple, imperfect revision, right? Do not, just get stuck on one page with perfection. I'll do this like this. Anyway, we have to forget now. So I am saying that instead of that, if you look at something multiple times, that gives you a better memory. So 3 to 4 times if you have done, I can assure you, you will be in a position where you see an MCQ, four options, you will be able to rule out the wrong ones and choose the correct one. And majority of the question paper will be solved like this only, that is by our subconscious knowledge. Active recall, like you see a question, you know this is the answer verbally, will be very few questions, right? So don't have this unnecessary and expectation and make yourself feel bad. You deserve to be happy, my friends. I know this is an exam, this is a bad situation you're going through, but you deserve to be happy. There is nothing more than this. I know this sounds like too philosophical right now, but you will understand this. What is the use of getting depressed and doing all this, right? So let's console ourselves, say that, look into the mirror, say, I deserve better, and I'm going to crack this exam somehow. That thing, manifestation, as they say, that works, right? So I know some of you may believe it, some of you not. Okay. If I say it from the angle of just some hope, I don't know. Like I'm a mere human being. I don't know if it works like that. But I can tell you one thing. If you get up in the morning, look at yourself and say, I'm going to do it, that attitude releases neurotransmitters in the body. And this scientifically, obviously, the neurotransmitter gets you going. Okay, that I can tell you. And once you're doing the work, obviously the result is waiting for you only. Who's going to pass this exam? Somebody who's not studying? Of course, no. It's you. You are the one who's going to pass this exam. Logically, right? So that's it. So I hope now you have a sane mind that we will do it. We'll take care of this. Let's get started. Okay. So here we are, my friends. You may remember this basic definitions, pharmacokinetics and pharmacodynamics. Kinetic means I took a medicine, the medicine moves inside my body under this four headings, absorption, distribution, etc. That means this is what my body does to the drug. And then there is something called pharmacodynamics. What is dynamics? When I took a medicine, the medicine will do something back to me. That means the reason I took a medicine is for the dynamics purpose. It produces some effects. That is called dynamics. Okay. Now we know all these roots. Enteral means those who come in contact with GIT. Please remember the drugs that are Tide or ACE, they are the oral drugs. I mean, Tide or ACE are protein drugs. They cannot be given orally because some enzymes in our body called peptidases break them down. Okay. Now that we have said these things, from this I can remind you of one important point. So, sir, I'm just revising from the main notes. Keep the workbook in front of you as a reference, and you keep revising like this. Now, I told you the way we can differentiate between intravenous and intradermal is simply like this. In intradermal, there will be a bubble formation called bleb formation. Okay. Why? Because you're putting the drug under the skin right now. And if you put some liquid under the skin, it will lead to swelling. Are you all understanding? But if you put this liquid in the bloodstream, that will flow from here. That's why you don't expect a swelling. So bleb formation is a feature of intradermal. Okay. Now these are some basics as I told you. Now we are going to focus on the pharma aspect. Okay. Now that the roots and everything is over, see the heart of this chapter called ANS, this picture. You need to know, how does the parasympathetic system work? How does the sympathetic system work? Parasympathetic system, there is a neurotransmitter called acetylcholine. So if acetylcholine increases, then there are certain receptors on which acetylcholine will work called muscarinic receptor. And sympathetic system works by neurotransmitter like noradrenaline. And what will this noradrenaline do? It will work on alpha or beta receptor. alpha or beta receptor. So now that we have gotten this much, let's try to understand. Hoping that all of you remember this mnemonic called dumbbells, right? We know some functions will happen when parasympathetic increases, meaning what will happen? Defecation increases, urination increases, meiosis will happen, bronchoconstriction, bradycardia, emesis, lacrimation, salivation. These are all the features when parasympathetic system increases. Now the question is that how does parasympathetic system increase? There might be drugs who will increase acetylcholine levels. If you increase acetylcholine levels, what will happen is there will be action coming on muscarinic receptor. Logically, right? If a neurotransmitter increases, it works on the receptor and you will get these functions. So who are the drugs who will increase acetylcholine? Hence, they will increase this dumbbells word. The answer is stigmine drugs. Hoping you remember this, neostigmine, pyridostigmine, they increase acetylcholine. That means they can produce dumbbells for you. Next, there are drugs who can directly stimulate this receptor called muscarinic. They are called as COL. So we got two guys, one called stigmines, one called COL, right? Stigmine and COL. Hoping everybody is clear with that. Now, since we have seen this, what is COL, what is stigmine, they both produce same effect, that is dumbbells. Now imagine that. Whether it's a stigmine, whether it is a COL, they're producing same effect, so they may be used in similar diseases. For instance, they're increasing defecation and urination. Now you should understand which is the person in which I want to increase defecation, urination. Somebody who can't urinate, somebody who can't defecate. We learned it earlier by the word post-operative ileus and urinary retention. Okay. I'm hoping you guys understand that post-operative ileus and post-operative urinary retention. Those are the people I want to increase defecation and urination. So we can use a drug like bethanechol and we can use a drug like neostigmine. Okay, these are all written in your notes one by one. I'm now giving you an overview right here. Next is meiosis. You must remember meiosis can help us in glaucoma disease. Okay, now you can refer to your glaucoma. Check this out. How does meiosis help in, glaucoma later? Please remember, meiosis increases trabecular meshwork drainage. That is how it helps in our disease called as glaucoma. So one drug you must know in this, it's called pilocarpine. Pilocarpine will stimulate this meiosis and this will be helpful for treating the glaucoma disease. Okay. Next, after we are done with this, okay, what do you think can happen if I block this picture? Everything will be, opposite, reversed. Defecation will be decreased, urination will be decreased, meiosis will decrease called mydriasis, bronchodilation will happen. So all these functions will be reversed. The drugs who block this are called the tropes. The drugs that block this, they are called as trope. For example, atropine. Atropine is a muscarinic blocker. That means it will not produce dumbbells, it will produce effects opposite to dumbbells. For instance, if I have blocked this, can I say I will get bronchodilation by the drugs called tropes? Yes. So this bronchodilation will help me for treating the diseases like COPD, asthma. Yes or no? So I'm simply saying that trope drugs are useful in the asthma disease or COPD. Why? Because we are blocking, which will produce bronchodilation. Now that we have a good overview here, I hope we can move further. This is one picture that I want to address here. See, when I said acetylcholine increases, I said it works on muscarinic, but you should also remember it also works on nicotinic. And nicotinic receptor causes skeletal muscle contraction, and this guy causes more parasympathetic function. Now that we have said this much, check this out. Doctors, assume if I block this receptor, obviously parasympathetic function will reduce. Those drugs were called as trope. Okay, you should know what effects will happen opposite of dumbbells. Okay, next, now that we have said this, second situation. What if I block this enzyme by a medicine called acetylcholinesterase? If I block this enzyme, there will be more acetylcholine level. More acetylcholine level means more muscle contraction and more parasympathetic. Okay, more muscle contraction and more parasympathetic. These drugs are called stigmines. Stigmines will block this enzyme. They will increase acetylcholine, which will cause muscle contraction and parasympathetic. Now, obviously, some diseases you want to treat by increasing the muscle contraction. What are those diseases? Myasthenia gravis, cobra bite, muscles get relaxed, right? Patient can die of respiratory failure. What do? I will give the patient something called as stigmines. Because if you have a relaxed muscle, you may die by respiratory failure. I will contract the muscles by giving the medicines called stigmines. Okay. Now that this is there, okay, let us see. I already mentioned this drug to you called pilocarpine, which is the drug preferred in closed angle glaucoma. When it comes to the open angle glaucoma, we know there are some drugs called latanoprost, etc. We'll talk about it later. Okay. Now in this page, I would say pilocarpine is more important drug. Okay, you must know this. Cevimeline for exam, less important. I mean, it's not tested like routinely or anything. Although I told you cevimeline is used in Sjogren syndrome. Okay. Sjogren syndrome is a disease of dryness. Next is somebody called bethanechol. So if you talk about bethanechol, I used to give you the hint. Chol means cholinergic drug, increases parasympathetic. B for bowel and bladder. So this is the drug used for post-operative ileus and retention. Okay. Next, if you see the stigmine drugs, we know these are stigmine drugs. I have told you stigmine means what, sir? It is a drug that block acetylcholinesterase, which will increase acetylcholine levels. And what did I just teach you here? If you block this enzyme, when acetylcholine level increases, there will be two effects. One is muscle contraction, and the second is increase in parasympathetic. I already told you where do you want to contract the muscle? Myasthenia gravis, cobra bite, curar drug toxicity, etc. And where do you want to increase parasympathetic system? Certain places where it has become less. Okay. So now let me take you further here. So, sir, there's a disease where acetylcholine becomes less called Alzheimer. So this is the disease, Alzheimer, where I'm going to give you these drugs, treatment of Alzheimer. Now you must know from this the best medicine is donepezil. Rivastigmine comes in the form of a patch. Tacrine is T for toxic. We don't use it anymore. It is hepatotoxic drug. We don't use it anymore. Okay. So one is over. Now, next, if you check this out, physostigmine. If you check, I told you physostigmine is used in the treatment of diseases called BAD. Okay. Treatment of diseases known as BAD. Now, what is BAD? Three diseases where parasympathetic is less. Belladonna, atropine, datura. These are the diseases where parasympathetic is less. And what do I want to do when parasympathetic is less? I want to increase it. I want to increase it, and for that, I will be giving physostigmine. Okay? physostigmine is useful to increase parasympathetic. And when do you want to increase parasympathetic? When it has become less. And what are the diseases where it is less? Back. And you must have written in the notes, how do these people with back come to us? Opposite of dumbbells. What do you mean by opposite of dumbbells? Constipation, urinary retention, mydriasis, etc., etc. Okay. And here's where we have already said these drugs like stigmine, especially neostigmine, it is used in two muscle relaxation diseases like cobra bite and curare toxicity. Cobra and the curare toxicity. Done. Now we have a disease called myasthenia gravis. I told you for diagnosing myasthenia. Okay, for diagnosing myasthenia, we give a short acting drug which makes the patient feel better if he has myasthenia. Okay, so this is a drug called edrophonium, the test called as tensilon test. Okay, this is it. This is known as tensilon test. All right. Next, after this, what we got is the treatment of this diseases, that is pyridostigmine, that is more longer acting than neostigmine. Hence, this is the drug of choice. Okay, that's about it. Next comes this farmer story called organophosphates. Organophosphates are poisons. Basically, what they do, they block acetylcholine esterase irreversibly. Permanently, they block this, leading to excess levels of acetylcholine. Not just little increase, it is massively high levels of acetylcholine. So you must remember something here. What will happen if a farmer comes to you with this pesticide poisoning? They will have features called dumbbells. Now, I explained to you in detail back in the day that dumbbells, when you look at this much part what I've highlighted is nothing but what we studied before. Okay? Diarrhea, urinary excess, meiosis, etc., etc. But one L is different in this list. Okay? What is this L? It is lethargy. Now you must simply understand this. Except for lethargy, every feature in this disease is due to a receptor called muscarinic. Whereas this guy is due to a receptor called nicotinic. If you remember, nicotinic receptor gets angry due to too much levels. And what happens? It gets desensitized. Okay. So receptor desensitization leads to this. So patient is coming with excess parasympathetic function due to excess, muscarinic receptors. So what we do, we give a drug called atropine. Now what atropine does is atropine will block this dumbbells because atropine is which blocker? Muscarinic blocker. Since atropine blocks only muscarinic receptor and it doesn't work on the nicotinic receptor, what happens, my friends, is lethargy cannot be controlled. Okay, lethargy cannot be controlled. So this is the simple logic right here that we have gotten. Okay. Now, since we learned all this, next is anticholinergics. Okay, anticholinergics. Anticholinergic means those are the drugs that will be blocking parasympathetic. Please remember from this topic, Botox is going to be important. Botox is that guy that blocks the release of acetylcholine. Botox blocks the release of acetylcholine. Now, you must understand if acetylcholine is less, the muscles will relax. Okay, the muscles will relax. And logically speaking, the muscle relaxation can help people who are having some contraction. That means this relaxation can help you treat some kind of a contraction. Did you understand this? And these are all examples of 1-1 contraction. That's it. Okay, this is about Botox. Now, before you send me a text, my friends, that should I only read what you are teaching in rapid revision? Again, I'm reminding you, this is a rapid revision where we focus only on the main things. Nobody can guarantee only questions can come from this. Now, you want to take the risk, only read the main things and go, because you are a person who's like, sir, this subject is not for me. Do that. We are lucky enough, you will get around 60 to 70% questions, mainly from the things that I'm telling you. All right. I can tell you the topic, but things inside it you have to read properly. Are you understanding that? Now you're a person who know this topics decently well. Then read the full workbook. You'll have a more chance. You can score 95% or so if you read the full workbook. Now you decide your target, how much you want to score, right? Sir, nobody can give guarantee as I'm telling you. If examiner is cranky on the time when he was setting a paper, that time if he gives something from outside the main topics, then you will suffer. So again, it depends. You are good in many other subjects. That means you're scoring very nicely. Then you can balance that if you read main parts only from this subject. You're already shaky in other subjects also. This is also one of the main subjects of part one. You can't take this lightly. You have to study it decently well then. Okay. So I hope I've clarified. So please don't ask me the same question again. Sir, should I read everything? Should I only read your marked stuff? Okay. Now, next coming to muscarinic blockers. So if you talk about muscarinic blockers, these are the drugs, again, they will produce opposite of dumbbells, you can think, meaning they will reduce the dumbbells. For instance, I said they will produce bronchodilation. Hence, they're used in asthma COPD. You must know the drugs like ipratropium or tiotropium. See, they're having tropium in the name. Trope names are muscarinic blockers. Okay. Now you must remember their common side effect is dry mouth. Next, if you check anti-secretory drug called glycopyrrolate, it is reducing secretion. So it's given before surgeries to prevent aspiration. Next is eyes. If you talk about the eyes, my friends, blocking parasympathetic will produce mydriasis as well as something called cycloplegia. So I used to teach you cat drugs, if you remember. These drugs are used for eye exam. Okay, they are used for the eye exam. The one preferred in children is atropine ointment. This one is preferred due to strong cycloplegic effect. Okay. Now this is the mnemonic park your Benz, if you remember. We use these drugs in drug-induced Parkinson treatment. Right? Park your Benz. Now, when you block parasympathetic, what happens to urination? It decreases. Urination decreases. So that's why we use them in overactive bladder. Okay. Now, we must understand there are two types of drugs in this. One are non-selective. Non-selective means they will block muscarinic receptor in many parts of the body, including urination, meaning blocking muscarinic will reduce urination, but it will produce other things as side effects. Are you understanding that? Blocking muscarinic in unnecessary places will produce side effects. So that's where we created a drug who mainly works on this system, that is urinary system. Those drugs are called uroselective. From this also you must know darifenacin. Remember I used to teach you D for decreases urination. Darifenacin decreases urination. This is what you must know. Next, one of the drugs called trospium, it does not cross blood-brain barrier. Since it does not cross blood-brain barrier, it will be safe in some CNS diseases like Alzheimer. Okay, trospium is a drug that is safe in Alzheimer. Okay, so you must remember D for darifenacin. It decreases urination, and trospium safe in Alzheimer. Done. Next, when it comes to GIT, if you block M1 receptor, I told you M1 receptor increases acid. So when you block M1 receptor, acidity decreases. There are drugs like Zepine drugs, pyrazepine, etc. They will be used in GERD, etc. Okay. Next, we got antispasmodic. Antispasmodic, not that high yield for exam. I can say antiemetic. This is important. Scopolamine or hyoscine happens to be the drug of choice for motion sickness. It happens to be the drug of choice for motion sickness. Is that clear enough to all of you? Now, as you see this here, this is the drug for motion sickness, meaning some movement which leads to vomiting. You apply the patch behind the ear. Usually, they will ask you about the patch, not the tablets. Okay, so then this works for a long time. 3 days, you will have the action. Done. Next comes the sympathetic nervous system. Now, when you look at the sympathetic nervous system, remember some things here. First, memorize the receptor properly. So, when you're sitting to understand this, what do? First, make sure you know alpha 1 will contract some things like vasoconstriction. I used to tell you B for blood vessel, always remember like that. B for blood vessel, vasoconstriction, urethra constriction, mydriasis, like that. So alpha 1 will increase the BP directly because it's acting on the blood vessel. Na? Alpha 1 receptor is on the blood vessel. Next mnemonic, we said one heart, two lungs. Remember this? One heart, two lungs, meaning beta 1 must be remembered mainly for the heart and beta 2 mainly for the lungs. Okay. So first you memorize this receptor. For example, now we'll take this alpha 1. It causes mydriasis, it causes urethra constriction, it causes increase in BP. So if there is a medicine who comes and stimulates this receptor, okay. So I am saying that if there is a medicine who stimulates this receptor, which receptor? Alpha 1. Let's say that drug stimulates this. Don't you think the same functions can happen? Meaning mydriasis, urethra constriction, vasoconstriction will happen. Now that you got this, understand where you can use this. If I stimulate alpha 1 receptor by a drug, I am getting mydriasis, which can help me with eye exam fundoscopy. It is increasing BP, so it will help me with hypotension patient. Somebody whose BP is less, these drugs can be useful. Now, on contrary, there can be drugs who will block this alpha 1. If you block this alpha 1, what will you get? Opposite effects. For example, I will get urethra dilation. I will get vasodilation. Okay, I will not get constriction, I will get dilation. Urethra dilation at the level of prostate can be useful in the BPH patient. So alpha 1 blocker can be helpful in the BPH because it's causing urethra dilation at the level of prostate. Alpha 1b blockade is causing vasodilation. Vasodilation will reduce BP. So this can help me with hypertension. Yes or no? So this plus and minus game you should be properly aware. Did you understand this? This is alpha 1. Next, beta 2. Now you can check this out. Beta 2 receptor, if you stimulate, you're getting bronchodilation. Logic. If you stimulate beta 2, you're getting bronchodilation. But if you give drugs called beta blockers, what do beta blockers do? Beta blockers will block this receptor. Don't you think you will get bronchoconstriction now? Everything is opposite now. Blocking the beta 2, you will get bronchoconstriction. And you and I know this. Beta blockers, that's the reason they should be avoided in asthma. Okay, did you understand this? So I am saying that the drugs that stimulate beta 2, they can be used in the treatment of asthma because they cause bronchodilation. Apart from bronchodilation, they will do some other things that you see here. Make sure you know every function of beta 2. I've even discussed this in 25 important questions, the side effects of beta 2 agonist, etc. That question came in the recent INI set paper. Okay. So that's where I'm telling you, if you go and do my 25 important question series videos, do them 3-4 times on a 2x speed. Whenever you have some time, keep in touch with pharma just by revising through that. Many questions, hopefully, if you're lucky enough, will be coming from that. All right. Now that we have said this thing right here. So example, if I stimulate beta 2 receptor, we will call these drugs beta 2 agonist. I am getting bronchodilation, hence we use them in asthma. So if I ask you what are the side effects of these drugs, you should say these things, remaining other things become side effect. Hyperglycemia, hypokalemia, tremors, these are the side effects of these drugs. Okay, now that we have said this thing, what does beta 3 receptor do? Beta 3 receptor, if you stimulate, it will reduce urination. And which is a person in which I want to reduce urination? Somebody who's urinating too much, called incontinence. We had a drug called mirabegron. Mirabegron. Mira urination is always on. I used to tell you now, mirabegron. Mira urination is always on. That means she's having incontinence. Give mirabegron, right? So more or less, I've discussed these drugs right here. So in this topic, catecholamines, make sure you know this: adrenaline, noradrenaline, dopamine, etc. Okay, all these guys you should know. Now regarding this table, watch the last 25 important question series. I put a question on this and I told you how if they give you a graph, which answer should be chosen, why. Okay, so this graph you can cover from there with a question so that you have it in the head how the question will come. Because right now just the explanation of this arrows not that important. You must know if a question comes like this, then how do you choose the answer? Okay, so dobutamine, dopamine, these four drugs at least you got to know, very important. Okay, and especially from this adrenaline. We know adrenaline is the drug of choice for anaphylactic shock. It is given intramuscular on the thigh. Okay. And the route that we said is IM, that is preferred more than IV. IV has a more stronger effect on the heart. Since IV is better on the heart, we use it for heart diseases. Are you understanding? That's why we use it in cardiac arrest, etc. Now, concentration also you should know, the concentration used is 1 is to 1000. Although we write it 1 is to 1000, the translation comes to 1 mg adrenaline is present in 1 ml of liquid. Okay, so that's all about it. This is adrenaline. Now that we have said this, next is dopamine. Dopamine, it works differently on different doses. What do I mean by this? Low dose dopamine works on D1 receptor, medium dose works on beta 1, high dose works on alpha 1. D1 receptor causes diuresis, it causes renal vascular vasodilation, increasing the GFR, which can be helpful in patients with oliguria. Okay, are you understanding this? This is going to be helpful for patients with oliguria. So I'm simply saying something to you here, that is different doses works at different places. I'm simply saying that If a patient has cardiogenic shock with oliguria, then dopamine becomes the drug of choice because apart from increasing the BP, this drug can even cause diuresis. See, one thing you should fit in your brain, sympathetic system, meaning the system of stress, fear, fight, flight, increases BP. Just think in stress, our BP increases, right? So the guys who control this system, they will all increase BP. Who are those people? Adrenaline, noradrenaline, dopamine, they all increase the BP. So that's why they're used in one shock or the other. Depending on the extra effects they are used in some specific shock. Example, out of these three drugs, adrenaline, noradrenaline, and dopamine, who can cause bronchodilation? Answer is adrenaline because A for all, it works on all the receptor. Remember, this is where you can see this in your notes. I have written this A for all. It means it works on alpha 1, alpha 2, beta 1, beta 2, beta 3. This is the only guy who works on all the receptor including beta 2. Because it works on beta 2, it causes bronchodilation. Hence, it is used in anaphylactic shock. Other guys don't work on all the receptors. So, depending on where they work, they are preferred in one type of a shock or other. So, adrenaline, anaphylactic shock, noradrenaline, this drug is preferred in, septic shock, and dopamine, cardiogenic shock with oliguria. So if I tell you which one causes diuresis, your answer should be dopamine, hence used in oliguria. I mean cardiogenic shock with oliguria. If I tell you best drug to increase BP, okay, best drug to increase BP, then the answer is noradrenaline. It's a very strong vasoconstrictor. Okay. Now that we have said this from this topic, keep an eye on tyramine. Tyramine increases the release of neurotransmitters, leading to more blood pressure, severe hypertension, called as cheese reaction. Now, this cheese reaction especially is seen in patients who are taking drugs called MAO inhibitors, which are antidepressants. Okay? MAO inhibitors, if you're taking, already the neurotransmitters are high in the body. Now, if you drink wine or eat cheese, more tyramine is released, more BP, this will happen. Okay. Next is these drugs like methylphenidate or modafinil. Methylphenidate, this is the drug of choice for ADHD, attention deficit disorder. Modafinil, on the other hand, it is the drug of choice for narcolepsy. Narcolepsy means excessive sleepiness. Okay. Now coming to alpha 2 receptor drugs, alpha 2 agonist, we got two guys here called methyl dopaclonidine as the most important ones. Methyl dopa, this is the drug we use in pregnancy induced hypertension. Although we use it in pregnancy induced hypertension, it is the drug of choice. I mean, it is not the drug of choice. The drug of choice in this disease is labetalol. Okay, the drug of choice will be labetalol. Next is clonidine over here. Clonidine, it is used for hypertensive urgency. What is urgency? It is high blood pressure without organ damage. Without organ damage, that is called as urgency. Now, do remember their side effects, please. Coombs test with methyl dopa, important. Rebound hypertension. If you stop clonidine or if you miss some doses of clonidine, your BP shoots up very high. As long as you're taking clonidine, it keeps the BP low. It lowers the BP. But if you suddenly leave this drug, then the BP shoots up extremely high, called as rebound hypertension. Okay. I already told you mirabegron. Remember, beta 3 receptor, you can go back and check. It reduces urination. Since beta 3 receptor reduces urination, it is useful for incontinence. Mira background. Mira is always on, right? That's what you will know. Beta 2 agonist, I don't think I need to explain. Bronchodilator, logical thing, used in asthma. Please remember, if I'm having attack of asthma right now, I'm unable to breathe. I need fast acting drug. Three drugs from this are fast. They are the fast drugs, what I have highlighted. The slow drug is salmeterol. Because it is slow, it cannot be used in emergency. Okay, salmeterol can only be used in prophylaxis or prevention, but it cannot be used in acute attacks. Remaining, as I told you, side effects of this already we discussed. It's important. Now, again, a high yield topic, sympatholytics, meaning alpha blocker, beta blockers. Now, there are different generation of alpha blockers. I'm just going to tell you the essence of this. The non-selective alpha blockers, they're very strong drugs to decrease BP. They strongly decrease BP. Okay. Since they strongly decrease BP, that's why they should only be used in very severe hypertensions. Example, we know big name phenoxybenzamine. This is used for a big tumor name called pheochromocytoma. It's not used to treat the tumor or the cancer, right? It's used to control the BP that happens in that thing, right? The mnemonic I teach in class, remember? P and H, palpitations and hypertension, main features. So hypertension can be blocked by giving a drug called phenoxybenzamine. Phentolamine, on the other hand, is preferred in cheese reaction or rebound hypertension. So all of these are severe hypertensions where I'm going to give you phenoxybenzamine, phentolamine. Next is alpha 1 blocker. Alpha 1 blocker, you got somebody like prazosin. Now, when you talk about prazosin, we got this PR word. What is this PR? PR means pressure plus prostate. Okay, PR means pressure plus prostate. So you can take that as a mnemonic and remember that it's used for those people having pressure problem called hypertension. Plus prostate means BPH. So prazosin, it is the drug of choice for somebody having hypertension with BPH. Is that understood? Okay. Next is alpha 1A blockers like tamsulosin or silodosin. These drugs are drugs used only for BPH. Now, point to be noted, my friends. The drugs above, they reduce BP. Hence, they can cause a side effect called hypotension. Okay? They can cause hypotension as a side effect. But these drugs do not work on blood pressure. They are only working on the prostate. So they don't cause the side effect that is hypotension. Okay, hopefully it is clear. Next is beta blockers. Now, when you talk about the beta blockers, okay, when you talk about the beta blockers, if a beta blocker blocks beta 1 plus beta 2, if it is blocking both of this receptor, then that drug is called non-selective. I've given you the hint right there. You can see how to remember them. Next is cardioselective. Cardioselective, they mainly block beta 1. Although in clinical reality, I tell you that they work like this. Okay. So more or less, you can remember they definitely block beta 1. They block beta 2, more or less. It's like that. It's not 100%. You can't say they work only on beta 1. Okay. So are you understanding? Now, I told you already, if you block beta 2, it causes bronchoconstriction. Hence, they should be avoided in asthma. Beta blockers, they should be avoided in asthma. But because the second generation is not blocking beta 2 as much, it's blocking little bit. So that's where they become safe in the asthma. Imagine this is my bronchus. There are 10, okay, beta 2 receptors on your bronchus. These are all beta 2 receptor. So when you stimulate beta 2, what will happen? Bronchodilation will happen. Okay. So now I'm saying beta blockers are blocking beta 2, they are causing bronchoconstriction, hence they should be avoided in asthma. The first generation, you can say that they block almost every receptor. So the bronchoconstriction with first generation is very, very strong. Second generation, on the other hand, they're not blocking the beta 2 receptor too much. They might be blocking only two receptor. That means remaining others are still working. That's why they are safe in asthma. Although they also cause bronchoconstriction, compared to the first ones, they are safer. Okay. I hope everybody got this loud and clear. So now this is done. Longest acting is nadolol. Okay. Timolol is used in glaucoma. Why? Because they're non-selective. They're not only for heart disease. Beta blocker means many people know them as the drugs for heart. Yes. Non-selective means they're used for heart plus some extra uses. For example, timolol is used in glaucoma. Next is cardio-selective. Now in the cardio-selective, you must know something here. The most cardio-selective is nebivolol. What do you mean by most cardioselective? That means this drug works more on the beta 1, very less on the beta 2, right? Very less on the beta 2. That's why it's called cardioselective. Now, listen to my next statement very clearly. Based on the cardioselectivity, I have written this drug in the second generation. Yes, I have written it there. But actually, if the question asks you, you can go for the third generation. If they ask nebivolol, you can answer what's a third generation. Why? Because if a drug is having some extra property, it should be called as third generation. For instance, if you check this drug also, celiprolol is also classified as third generation because of the extra properties it has. Okay, this also I'm going to call as third generation. Nebivolol also I'm going to call as the third generation. Heart की वजह से, based on how much they work on the heart, I put them in cardioselective. But actually, if exam asks you what generation, you should be choosing third. Not for everyone, for those who are having this extra properties. Okay, are you all understanding that? So now that we have said these things here, more than the uses, what they will ask you in the exam is the side effects. I mean, where you should not use them. The mnemonic, very bad choice. Please refer to that. Remember this. Now, the next chapter is going to be hypertension. Now, you must all understand, doctors, how exactly can I reduce hypertension? Headings are loud and clear. One thing I can do as a doctor is I can reduce the sympathetic activity. The drugs we already learned just now, we won't be studying again. Next is drugs which are vasodilator. That means this is a blood vessel. Okay, this is a blood vessel. Now, what can be there on the blood vessel? There can be a channel called potassium channel. Now, you know there is a endothelial layer here. Endothelial layer has somebody called nitric oxide. Next, there is a calcium channel. In fact, there are more things also. I am saying that calcium, if it enters, it will cause contraction. Calcium causes contraction of everything. So if you block this calcium channel, obviously it will lead to vasodilation. Nitric oxide causes vasodilation. So you should stimulate nitric oxide. Okay. That will cause vasodilation. Potassium channel, if you open, again you will get vasodilation. So by different mechanisms, we are working in this topic. Now, once you know vasodilators can be nitric oxide drugs, potassium drugs, or calcium channel blocker, we can move further. So what are the drugs in the nitric oxide? We got hydralazine and nitroprusside. Both of the drugs are strong drugs to decrease BP. Hence, they are used in hypertensive emergency. Okay, they are not drug of choice, they are alternate drugs. If the drug of choice cannot be used for some reason, maybe, then we'll be using these drugs. For example, labetalol is the drug of choice for emergency in pregnant women. IV labetalol, it is the drug of choice for controlling hypertensive emergency in pregnancy. Alternative medicine is hydrolysis. Okay. Next, if you talk about normal people, the drug that we generally prefer is nicardipine. Okay, normal means non-pregnant or males. In those people in emergency, what do we use is nicardipine. Nicardipine is the drug. We can even use labetalol and nitroprusside. These are like the alternative medications. All right. Next, we got these guys, that is potassium channel openers. Okay. They are the drugs called potassium channel openers. Now, since we see this potassium channel openers, we got this mnemonic here. I hope you remember MDH masala pack. Please do remember we are opening this pack. Topical minoxidil. These drugs are used more for their side effect rather than their uses. Minoxidil is used for hair loss. Diazoxide is used in insulinoma. Okay, it's used in insulinoma. Now, if you talk about the CCB, calcium channel blockers, dipine drugs are used to control BP. Dipines work on the vessels. These drugs like verapamil deltaism, they work more on the heart, very less on the blood vessel, but they do work on both places. So these are also drugs we can use in hypertension, but they're not preferred. What we generally use to control BP is dipine drugs. I just told you nicardipine, it's the drug of choice for hypertensive emergency. Nifedipine is used in preterm labor because it's a tocolytic drug. It relaxes the uterus. Okay. Nimodipine works in the brain. It's cerebroselective, so it's used in subarachnoid hemorrhage, etc. Now you got this side effects. Okay. Now that we have said this, I'll give you one trick, sir, what you can do. Okay. Now that many of you must be studying pharma after quite a while, unless some batches which I did very recently, that is a different situation. So I am saying that first, what do you do? Read pharma first time when you are giving a look after listening to this rapid revision. First, you go to the entire workbook, go through this. Just learn the drug and their uses. Meaning, if I tell you dipines, you should be knowing the drug of choice for emergency is one of them, nicardipine. So, first drug of choice you should get familiar, and some other uses if you have. So, first reading full workbook, what you should do, just the uses. Next, what can you do? Second time when you come back, look at the side effects only. Don't read the uses second time. What do you do? Second time when you come, you will do only the side effects. And now when you're looking at the side effect, indirectly your brain will revise the uses again. When you come to the beta 2 topic, beta 2 agonist example, now you're revising the side effects of beta 2 agonist. Your brain will already see the salbutamol, salmeterol. It will know, oh, this is asthma drugs. Now you will again read the side effect. Did you understand? This is the trick I want you to follow. Right? Do it in parts. Ek saath, if you want to do everything, it becomes slightly more challenging. Okay. Now that we have said this is a system called as RAS. Okay. Now, when you look at this RAS, what I would want all of you to understand is this. Okay. You must see these things right here. RAS increases BP, one by acting on a receptor called angiotensin receptor and by controlling the sodium. So, two ways it's going to increase your blood pressure. So, although this picture is written like this, imagine if this picture was written straight. Okay. So renin, angiotensin, aldosterone. This is the sequence. If the three happens, if this gets stimulated, then the BP increases. Then the BP increases. Now, if I block this guy here, this picture cannot happen. That means from here, there is a blockage that has happened. My drug has blocked from here, so BP will reduce. Situation number two, if you block angiotensin, again the BP will reduce. If you block aldosterone, again the BP will reduce. So simply the point is, if you don't let this arrow function, your BP will reduce. So you got these drugs here. Okay. Beta blockers like LOLs, direct renin inhibitors like Kirin. Kirin is inhibits, renin inhibits, renin, that's the word. Okay. ACEs and ARBs. What is meant by ACEs and ARBs? The drugs called as Prils and Sartan. Prils and Sartan. Very important. BP, you will get some question from this. Last FMG exam, we had 4 questions just coming from the hypertension chapter alone. Okay. So it's a crime not to study this chapter, sir. Okay. Now, ACE inhibitor and ARB, Prils and Sartan, Prils and Sartan. They are the nephroprotective drugs. That's why they are preferred in people having diabetic nephropathy and CKD. This was one of the question in last FMG. Okay, they're nephroprotective drugs. Next, do keep an eye on these sartans which have some extra effects. Now you must remember ACE inhibitors, they increase a substance called bradykinin causing these side effects. ARBs do not do that. Next point is this. These drugs, ACEs and ARBs, are contraindicated in pregnancy also, as well as one kidney disorder called renal artery stenosis. Last is spironolactone. This drug is used for resistant hypertension. Now, what is resistant hypertension? When 3 drugs are not enough to control the BP, fourth drug is added. Fourth drug. What is this fourth drug to be added? Spironolactone. That is called resistant hypertension. Next, you must keep an eye on this table here, page number 26. You got these 2 things written in your notes. If a patient is having only hypertension, then you should be choosing between these drugs called ACD. What is ACD? A stands for ACEs and ARBs. For BP control, ACE inhibitors are slightly more better than ARBs. Although both are used equally, but I am saying between the two, slightly better is ACE inhibitor. Next is CCB, depends mostly what are used. Then diuretics like thiazide. So I am saying that these are the drugs you should be choosing in a patient who is having only hypertension. ACEs and ARBs are used for younger people who are below 55 years. CCB and diuretics are used for people who are, above 55 years. Next, read this. If a patient is having hypertension with some extra disease, then which drug to be chosen for this? Read that table. You will get a question from that. Okay. Now that this is done, my friends, the next part is diuretics. Diuretics means, simply put, consider this all tubes. Okay. This is nothing but urine. In a simple language, this part, all of it is nothing but urine. Urine is passing in the tubes like this. This is your urine here. Okay. Now understand there is blood vessels next to this. That means blood is there. So what happens now is if something is important, there will be channels here like this coming in this direction. If something is important for your body, it will not be allowed to go out of the body through urine. We won't allow it to go back. See, what will happen now is if anything is important to me, it comes back by this channels. This is called reabsorption. For example, sodium. Sodium and water gets reabsorbed in every part of the nephron, that is PCT, DCT, etc., etc. So now, if I want to lose water because patient may be having too much water already called edema. I will give you a drug called diuretic. What will the diuretic drug do? It will block this reabsorption, meaning now the drug will not be able to come back into my body. Okay, so basically the sodium will not be allowed to come back. This is all I'm saying. Diuretics, what do they do? Diuretics, they block the reabsorption. Okay, now since this is done, this is what is done by diuretics. Sodium is lost in the urine along with water. It's not just the sodium. If this channel was meant for some other guys to come back, they also will be lost. So along with sodium, you will lose others. So we have this part that is where the urine is. This is your PCT. This is your loop of Henle. This is your DCT. And this is your collecting duct. And obviously, from each part, as I told you, what is happening, reabsorption is happening. Different drugs block at different location. So already it's written in the notes here. I made you write the most important examples. Please read them. It's already highlighted in your notes if you were there in the class. Now just quickly revise. Loop diuretics are preferred in pulmonary edema. They are preferred in pulmonary edema. Loop diuretics make you lose everything. There is a mnemonic written, loops lose all. They make you lose sodium, potassium, chloride, calcium, and magnesium. Everything is lost with loops. Exactly one difference here with thiazide is they also lose pretty much everything. With one difference, that is what, sir? They save calcium. Thiazides will save calcium. That's it. Okay. Now coming to potassium sparing diuretics. Why are they called potassium sparing? Because they increase potassium in the body. Okay. So we got drugs called aldo blockers, aldosterone blockers, example spironolactone. This is the drug of choice for edema in cirrhotic patients. Con syndrome, what is cons? Too much of aldosterone and resistant hypertension. That is where you're going to see this. Okay. Next is a drug called amiloride. Amiloride happens to be something called ENaC blocker. This drug is used in situation where there is too much ENaC. You should know by now there is a disease like Liddle's. Liddle's, there is too much ENaC activity. So we block it by this. Right? Now the rule of thumb is wherever potassium goes, hydrogen goes. So if you are having hyperkalemia, then hydrogen will increase. And if hydrogen, that is the acid, increases in the body, you will get acidosis. Are you understanding that? So increase in the potassium increases H plus, and this will lead to acidosis. Every now and then we get a question on gynecomastia drugs. Make sure you're remembering this. Disco mnemonic, disco drugs. Okay. Now, since you and I got that, next is acetazolamide. I've already taught you several times. Aceta, remember it as acidosis causing drug. It causes acidosis. So since it's causing acidosis, it can help you treat a alkalotic disease called mountain sickness. So diuretic may all you need to do know the location where which diuretic work with their example, furosemide, etc., etc. Then just learn the uses, right? One by one. Now the last and the final is osmotic diuretic like mannitol. Mannitol is drug of choice for cerebral edema. Okay, mannitol is the drug of choice for cerebral edema. Done. Next are the drugs called antidiuretics. Okay, antidiuretics. This guy is also called ADH, right? ADH, that is the word for antidiuretic hormone, also known as vasopressin. So you must understand vaso word, vessel, it causes vasoconstriction and it's causing ADH function, that is to save water. So if you give vasopressin to someone, their vessels will constrict, plus they will save water. Now there are drugs like that, but with selectivity in the receptor. For example, telepressin. It works only on one receptor called V1 receptor. This is telepressin. And this happens to be the drug of choice for esophageal varices. Okay. Next is desmopressin. It's a V2 drug. This drug, V2 means it will save water. So this saving of water can help you with two diseases. One is diabetes insipidus, which you can see, central or neurogenic DI. And second is nocturnal enuresis in children. Nocturnal enuresis in children. All right. On contrary, now you got vasopressin blocker. See, let's calculate. Vasopressin saves water. So if vasopressin is blocked by a medicine, you will lose water. Now you want to lose water in somebody who's having too much water in the body called SIADH. If you are having too much ADH, I want to block ADH. What is that ADH blockers called? Vaptans. ADH or vasopressin blockers are called as vaptans. Vasopressin antagonist. Okay. Vasopressin antagonist. All right. That's all. Heart failure, sir. Let me just tell you heart failure, what is important? Chronic heart failure. Okay. When you talk about the chronic heart failure, the idea is that in this, the aim of the doctor will be to reduce some things called preload and afterload in the patient. So basically, if you reduce the load on the heart, then that heart can survive longer. Right? It's a logic, right? If something is failing, you use it more, it will fail faster. So all I'm saying is in this, the aim is to reduce preload afterload. This can be done mainly by the drugs working on the RAS topic. So that means in chronic heart failure, block RAS. This is my aim, right? This is my aim. ACEs and ARBs, beta blockers, aldo blockers, they're all RAS blockers. So these drugs are usually used here. This is one thing. So there is this mnemonic that you all must memorize for this topic. Drugs reducing mortality, meaning they reduce changes in the heart called cardiac remodeling. Cardiac remodeling. This is the word you learn in medicine also now. So I am saying that these drugs, this mnemonic super cool bhai sahab, you must know. Okay. Next, when it comes to digoxin, digoxin toxicity is a topic they love to ask. So you must remember when it comes to digoxin toxicity, sir, this toxicity, they will ask you, why does it happen? Why did the toxicity happen in the first place? Your answer should be hypokalemia did it. Hypokalemia produces digoxin toxicity. And once there is digoxin toxicity, how do you treat it? That is the second thing. So you must know digoxin has now bound to my heart. Too much digoxin is now binding to my heart. I need to remove it from there. Now to remove it from there, I'm going to give you what? A drug called DigiBind. It binds to digoxin. DigiBind is somebody who binds to digoxin. Okay. Now that you have learned this, after this lidocaine. Lidocaine is given to control the arrhythmia part in this disease. Okay. Now coming to anti-anginals. This is not a very high-yield topic for exam. They may ask once in a while, but not a routinely tested topic. Heart failure, regular. Arrhythmia, regular. Hypertension, regular. Now nitrates. So what is one of the things you must know? Anti-anginals. What do you want to do in angina? See, in an angina patient, there is obstruction to the blood flow that is existing in this patient's heart. There is some blockage because of which this is happening. So what I can do is I can cause coronary vasodilation. If I cause coronary vasodilation, blood flow will increase, your chest pain will reduce. Or the second thing I can do is, when does the heart ask for more oxygen? Heart is a muscle. Any muscle asks for more oxygen. When you're exercising, when your heart rate is more, you will get chest pain. Okay. So what we can do in the treatment is reduce their heart rate, reduce the heart rate by drugs like beta blocker, calcium channel blocker, etc. That's all I'm going to do. So I'm saying that what are the most important drugs you must know from this? One is nitrates. Nitrates are drugs directly, the name says it, they work through nitric oxide. Okay, drugs like nitroglycerin, etc. They are, you know, the drugs that we are using abundantly in the topic of angina. Now you must remember nitrates are vasodilators. Logically, they can cause lower blood pressure, that is hypotension, right? Nitrates can cause hypotension. Now, if you figured this out, think about it. Don't you think we should avoid these drugs with other vasodilators? Yes, we must have written Viagra example there. You should not give Viagra to these people. Yes or no? We should not be giving Viagra to these people. Logical enough to all of you? Okay, done. Now, since you and I said this, Viagra is a drug that should be avoided in this patients. Okay, next we move further. There is a drug called dipyridamole. It worsens MI or angina because it reduces the blood flow to the infarcted tissue. I explained to you there is a side effect. Now, mechanism not needed, but coronary steal phenomenon. It is stealing the blood from the infarcted tissue. The one who needs the blood, it is not giving it. Okay. This is a guy called dipyridamole. All right. Next comes arrhythmia. Quick review on this. Check this out. This is the graph representing the electricity in the atria. Okay, it's representing in the atria. The first picture is the nodal cells or atria. Here, calcium and potassium is important. Here, sodium and potassium is important. So the first picture is atria, the second picture is ventricle. First, you should memorize who's important where. Calcium is in atria and sodium is in ventricle. So that logically tells me if I, see, first of all, what is happening here? These are cardiac events, meaning if electricity events happens, then your heart is beating normally like this. Okay. Now, for example, my heart is doing this contraction, relaxation, contraction, relaxation. If all these four things happen in time, then everything will happen in time. Okay. Let's say there is a 6 hour lecture I need to give. Example, 6 hour lecture I need to give. So obviously, if I start it in time, let's say by 9 a.m. it was supposed to start. Example, I'm saying, if it was supposed to start by 9 a.m. and end at some time. Now, if everything happens in time, I will be able to finish everything in time. But if there is a delay in anything, then this time taken will be prolonged. Instead of finishing by 3, now I may finish by 6. That means they will take more time now. So I am simply saying that what are the four things that should do their job in time? Calcium, potassium, sodium, potassium. Imagine by a medicine, I'm interfering with this. I'm stopping the sodium from doing its job. So now, obviously, the ventricular activity will be slowed down. Instead of finishing this much activity, example, in 1 second, now it will take me more than 1 second to do this, meaning the heart rate will now reduce. Are you understanding that? If you block any of this, the heart rate will reduce. Now you can simply memorize Since sodium is more important in the ventricle, sodium blockers will help you treat ventricular arrhythmia. Calcium blockers will be more helpful in the atrial arrhythmia. That is the logic we can keep in mind. Now you can see this classification that we have. I gave you a mnemonic which you can read right there in the notes right now. Okay. Now, once you have memorized which class is which, now you know sodium blockers can be used in the ventricular arrhythmia. Class 1 drugs are useful in ventricular. Class 4 drugs are used in the atrial. Okay. Now, once you are done with this understanding parts, let's keep one point in mind. If you block potassium channel on the heart, you will cause one arrhythmia called torsades, which is seen by QT prolongation on ECG. Okay, QT prolongation on ECG. This is the keyword right here. Done. Now that we saw this thing, we can understand these things here. Like if you talk about this drug called quinidine. Quinidine has quin in the name. Quinidine has quin in the name. So what you and I can remember is quinidine. It is used for this arrhythmias, ventricular arrhythmia, but it's originally a drug coming from malaria topic. How do I know? Quin in the name. Primaquine, tefenoquine, etc. These are all the drugs we use in the malaria topic. Yes or no? This is it. Now that you see this, now procainamide. Okay, procainamide. I want you to remember this thing here. Okay. After we have said this, there is a side effect of this drug called procainamide. So you must all remember this. The side effect of this drug is SLE. Okay, side effect of this drug is SLE. Okay, now that you have written this, Sarji, shipped drugs. There is a mnemonic that is shipped drugs. So this is one of the shipped drugs, right? Next, now that you see this thing here, class 1B, you need to know one drug called lidocaine, which happens to be the drug of choice for digoxin-induced arrhythmia. Next is flecainide. Now, for the flecainide, I want you to remember, please change it and remember it as the drug for, prevention of, it's used in WPW, but correct it to prophylaxis. Okay, maintenance we can go for flecainide. Sometimes we can use in treatment also, but mostly prevention. Mostly prevention of WPW will go for flecainide. Okay. Next thing is pheochromocytoma, PH, palpitation, hypertension. Hypertension, we saw a drug called phenoxybenzamine. Palpitation means heart now, so we need to give beta blockers. So beta blockers are the drugs preferred to control the arrhythmia in pheochromocytoma. Okay, cool. Now that we said this, class 3, we got somebody called amiodarone. So now if you talk about the amiodarone, this is a very long-acting antiarrhythmic. It's a very wide spectrum drug. That means it can pretty much treat every arrhythmia. Although it can treat pretty much every arrhythmia, but it is the drug of choice for ventricular arrhythmia. Okay, it is the drug of choice for ventricular arrhythmia. Okay, now since this is done, do keep an eye on the side effects I made you highlight back then. Now, as a reminder, there is a very repeated MCQ that is adenosine from this topic. So adenosine is a short-acting drug. To overcome this short action, I told you we give it in the central veins, by a rapid push. This is the drug of choice for treating acute SVT or PSVT. Since it's short acting, it can only be used in the hospital, sir. We can't discharge the patient on adenosine. So for discharging the patient, meaning maintenance or prophylaxis, same word. Maintenance also means the same. Prophylaxis also means the same. We give verapamil as drug of choice. So hospital mein what do you give? We give adenosine. But in the maintenance, that is during discharge time, what do you give? We give these drugs like verapamil or diltiazem, preferably verapamil. Last is lipid topic. What is my aim to do in the lipid topic? What do I want to do as a doctor? I want to reduce bad cholesterol called LDL. I want to reduce triglycerides. I want to increase good cholesterol called HDL. The only one different here is this guy. Other two I want to decrease. So I am saying that the drugs of this topic, they may work on all the three things, meaning they will do all this what we want, but they will do one of these three things best. For instance, there are drugs called statins. Statins are the best drugs, HMG-CoA reductase inhibitors, to reduce the LDL. They have more effect on LDL. Yes, they may also increase HDL and reduce triglycerides. Same way, there are drugs called fibrates. What is the story of fibrates? They have fibrate in the name, good name, fibrate in the name. Okay. Now, what they do, they reduce triglycerides the best. Okay, that's why they're the drug of choice for hypertriglyceridemia. Now that you said this, the question is this, doctors. How do they do this? They stimulate one factor called PPAR alpha. And when you stimulate PPAR alpha, it will increase one enzyme called lipase. Lipase will break the fat. Think of it like that. Okay. And the best drug to increase HDL is called niacin. Let's remember HDL as the nice cholesterol. Good guy, no? Good is also called nice. Niacin increases nice cholesterol. Niacin increases nice cholesterol. Now with niacin, you will get some side effects. Those side effects, if you want to reduce, you should also give aspirin with it. So this couple, remember it, niacin, aspirin, niacin, aspirin. Okay, we can simply remember it like that. All right, so that's about this. Next comes your epilepsy topic in the central nervous system. Okay, central nervous system. So, sir, if you talk about this, first you must know on the first page of the notes, remember I told you this. Seizures are the motor part. Seizures could be provoked or unprovoked, right? Seizures could be provoked or unprovoked. Provoked seizure means some disease has caused that seizure. Some reason is there. Unprovoked means it's called epilepsy. If you get more than two unprovoked seizures, then you might be categorized as a person having epilepsy. There is no cause. For example, if let's say I'm sitting calm and quiet normally, there is no problem in me. Suddenly I get a seizure. That is an unprovoked seizure. Without anything you get. So whether provoked, whether unprovoked, the first drug, the treatment you will give is a drug like lorazepam to stabilize the person. Okay. So what is the first treatment, whether it's epilepsy, whether it's a provoked seizure? The answer is lorazepam. Once the patient is stable, now the neurologist will see if this is an epilepsy case. If it is epilepsy, during the discharge, the neurologist will tell the patient for maintenance, you have to take this drug every day. So epilepsy drugs are given only for epilepsy. And who is epilepsy patient? Unprovoked. Randomly, they may get a seizure. Now that's why every day you have to take this treatment. Okay. Now you must keep in mind with seizure, what to block. I've already given the notes there, GTCS, your focal seizure, etc., which ions to be blocked. You have written all those things. What is status epilepticus? Seizure more than 5 minutes is called status epilepticus. Okay. Now, once we have said this, what do you need to know here? When we talk about anti-epileptics, okay, first one is a drug It's called wide spectrum because it works on all the four mechanisms I made you write in epilepsy. On the first page of the notes, you wrote how can we control epilepsy? By blocking sodium, by blocking calcium, by increasing GABA, and by reducing glutamate. So I am saying that all the four mechanisms are done by this drug, so it can do everything, hence wide spectrum. It is overall drug of choice for everything. Okay, it is overall drug of choice for everything. Listen to me carefully. In the chapter of epilepsy, if they ask you drug of choice, 90% your answer is going to be valproate. Some places you cannot answer valproate. What are they? Let's repeat. Listen to me now. Focal seizure. If they ask you focal seizure, then carbamazepine is the drug of choice. Okay, for focal seizure, carbamazepine is the drug of choice. Next, absent seizure. If they ask you absent seizure, listen carefully now. Ethosuximide is the drug of choice. Okay, but usually, this absent seizure comes with some other seizure, meaning absent seizure plus something else. So when you have something else, then you need a drug who can work on everything, no? So that's where this drug is preferred, valproate. So both are drug of choice. Ethosuximide is also drug of choice. This is also drug of choice. But if it's only absent seizure, then we may go for ethosuximide. But if there is absent seizure plus something else, then valproate. And mostly speaking, they will have something else with that. So overall drug of choice, what you need to answer in the exam is valproate only. Unless they very specifically mention typical absent seizure. If this is the word they have given, then choose ethosuximide. Okay? So I am saying that if they mention typical absent seizure, choose ethosuximide. If let's say they have given absent seizure along with something else, close your eyes and choose valproate. Let's say they haven't given anything like that, still choose, valproate as the answer. That's what I'll tell you. Okay, there is a difference of mechanism. This guy blocks only calcium channel. It's only used for absent seizure. This guy blocks calcium also, other things also. That's why it's overall drug of choice if they have some extra. So did you understand? If they ask drug of choice, generally speaking, for any seizure in this chapter, 99% you're answering what, sir? Or let's say 98%, you're answering valproate. What is this 1% that is changing? Focal seizure, if they ask you, then you will answer carbamazepine. Or if they ask you typical absent seizure, then you choose ethosuximide. Otherwise, most of the time, valproate. With good effects come side effects. The mnemonic I told you there to remember important side effects, apply that, learn. Lamotrigine is more or less like newer valproate. It is same wide spectrum, but it is having less side effects, something called Steven-Johnson syndrome. Okay. Next is phenytoin. Phenytoin is also a drug, sodium blocker. Sodium blockers are useful for focal seizure. Okay. You need to know this mnemonic very hot for this. This much mnemonic side effects you should revise. So these are facts. I'm not going to sit and read like what is very. It's written clearly. Vitamins are reduced by these drugs. It's written. Now what can I read about it? Obviously, as a doctor, vitamin K, if it is less, you will bleed, something called hemorrhagic disease. Vitamin D is less, osteomalacia. Vitamin B9 is less, megaloblastic anemia or NTD. So this kind of things I told you in the beginning, I'm not going to read everything. I'm reminding you, we are sitting together, brushing up the topics. Okay. Carbamazepine, it's a sodium channel blocker. Trigeminal neuralgia and for focal seizure, it is the drug of choice. Now, carbamazepine can increase ADH as a side effect. That means it will give you SIADH as a side effect. See, although the word originally is SIADH like that, but I always tell you to change it to upper arrow. So you get to know SIADH is increased ADH disease. Done. Levetiracetam, it is the safest drug in the pregnancy. Levetiracetam followed by lamotrigine. Okay. Next, sir, gabapentin, pregabalin, GABA in the name. These are the drugs stimulating the GABA's effect. Okay, they are stimulating the GABA's effect. So they will reduce pain sensation, etc. That's why they're usually used in reducing pain sensation in neuropathies. Neuropathic pains, I'm going to give you drugs like gabapentin, pregabalin, etc. Okay. Now this table highly important for us. ये तो रटना पड़ेगा बॉस. Status epilepticus, IV lorazepam, I told you. Febrile seizure, child with fever. Rectal diazepam or intranasal midazolam, both are drug of choice. Anything can be used. Okay. If you're having eclampsia, magnesium sulfate. History of seizures, I mean, epilepsy, even before the woman gets pregnant, she's having a history of epilepsy, then levetiracetam or lamotrigine. 98% your answer, valproate for almost seizure. Focal seizure, carbamazepine, what we had learned before. Okay. Next is a guy called sedative hypnotics. Okay, sedative hypnotics. So, doctors, the name says it, sedative hypnotics. Now, what you and I should know here is this, my friends. These drugs, they stimulate a receptor of GABA called GABA A receptor. They work over there. GABA will decrease electricity. The more these drugs will stimulate this receptor, the more the GABA will reduce electricity in the brain. Proportional, no? You will have this. So I'm simply saying that if you keep reducing electricity, all these uses will come. Okay, all these uses are coming due to reduction in the electricity. That is the logic here. Now that we see this thing here, sir. Okay, now that we see this thing here, please remember some differences. Barbiturates and benzodiazepines. Barbi means phenobarbital. Benzodiazepine means lorazepam, diazepam, etc. इसके नाम में ही है diazepam. Benzodiazepines, diazepam, lorazepam, they are the drugs in this category. Okay. Now, the most important repeated question. Flumazenil, it is the antidote of this drug. Okay. Benzodiazepine, the antidote is flumazenil. And since this drug doesn't have an antidote called barbiturate, what do? I told you drugs, if you see, they can be acidic in nature or they can be alkaline in nature. Alkaline drugs will have ene in the name. Acidic drugs will have ate in the name. Ene and ate. This drug is having ate. Folic acid is also called folate, so ate means acid. So just remember that barbiturates are acidic drug. To remove an acidic drug, make the body alkaline so that the drug becomes uncomfortable and gets out. I'll give you few seconds to process. Acidic drug should be removed by making the body alkaline. So barbiturates are removed by doing something called forced alkaline diuresis. Since the drug is acidic, remove it by alkaline. If the drug is alkaline, remove it by making the body acidic. That's all. Okay. So that's it. Antidotes. This is very important here. They will love to ask that. Keep an eye on the date rape drug. It's a drug called flunitrazepam. Flunitrazepam. This is the date rape drug in this topic. Okay. Now, since you have said this insomnia, etc., is not a high yield topic. Anyway, just to remember, I told you the word means sleep. Okay, this means sleep. So I am saying that this is the letter Z here. Zaleplon, zolpidem, etc. These are the drugs that we use for inducing sleep. Next is the topic that is depression. Okay, antidepressants. Now, here's where you have neurotransmitters who are reduced in the depression. They are decreased in depression. Who are these neurotransmitters? Serotonin, noradrenaline, and dopamine. They are reduced in the depression topic. So, what do I want to do? I want to increase them. How can I do that? Number one, stop them from breaking down. There is an enzyme who breaks them down called MAO. So if you give MAO inhibitor, they will increase now. That's how I can treat depression. Or the second way I can treat is they go back, they get recycled like this. Their recycling is called reuptake. I can block their reuptake by a medicine. They will again increase in the synapse. That's where you got reuptake inhibitors like SSRI, SNRI. What do you mean by that? Selective serotonin reuptake inhibitor, serotonin noradrenaline reuptake inhibitor. That are the names. Okay. So now since you have gotten that, important drugs from this to keep an eye on. One of them is TCA, tricyclic antidepressant. Okay, this is your TCA, tricyclic antidepressant. So what you and I must know, doctors, is simply this. This TCS, you got these drugs called triptylins. They're used for neuropathic pains, amitriptyline, nortriptyline, etc. They're used for neuropathic pains. Okay. Next is imipramine, etc. So imipramine is used in nocturnal enuresis. It used to be used, not anymore. Today, I think I told you this before, something called bed alarms are used for nocturnal enuresis. Bed alarms. These are the things that we use today for this. All right, guys. So, as we were learning, I told you that for the nocturnal enuresis, the treatment that we prefer today, it is called as bed alarms. All right. Now, coming to the side effects of these medicines called as TCA. Okay. So, what is these side effects? Sir, these drugs block one, they block a set of receptors, what I teach you as ham, histamine, alpha, muscarinic. So they are blocking these things, histamine, alpha, and muscarinic. So depending on that, you will get some side effects. For example, some time back we learned alpha 1 if you block, you will get hypotension. Okay, you will get hypotension. So now that we have gotten this, next, after this, if you block muscarinic, opposite of dumbbells, dry mouth, blurred vision, etc., etc., all these things will happen. So, simply put, you need to know the side effects when it comes to the TCA, tricyclic antidepressants. Okay. Next thing is these guys, what we call as SNRI. So, what are these SNRI if we check? These are the newer drugs that we use for the depression. Okay, newer drugs used in depression. So the medicines that come in this list, when we talk about this, they are drugs like venlafaxine, duloxetine, etc. What is very important for us is this medication called duloxetine. So duloxetine is used for stress incontinence. So again, you need to memorize it decreases urination. Duloxetine is once again somebody, what is it doing, sir? It decreases urination. So now that we wrote this, we got the last medications which are important in this list called SSRIs. You must know SSRIs happen to be the drug of choice for depression. Not only they're used for depression, but they're also used for most of the neurosis as well. Now, in psychiatry, you have diseases called neurosis and psychosis. So, neurosis are those diseases which are more milder diseases, and patient has insight present in them. Okay, so that's it. Now that we have gotten that, keep an eye on these names like fluoxetine, citalopram, sertraline. These are the three examples I'll say is important. The commonest side effects of the commonest side effects of SSRIs is nothing but, they cause vomitings. Okay, they cause vomiting as the side effect. Done. MAO inhibitors are anyway not preferred anymore. Remember, I told you MAO inhibitors are those that may cause this cheese reaction, etc. For this reason, we are not going to prefer them. Okay. Next comes something called as bipolar disorder. Now, when you talk about the BPD or the bipolar disorder, you must keep in mind that bipolar disorder name is given when a patient is having two diseases, that is mania and depression, both, right? So that is a patient called as bipolar disorder. Now, this patient may be fluctuating between these two diseases. For some time, the patient may have mania, and for some time, the patient may be depressed. Now, you should understand the drug used for the maintenance of this patient. Maintenance means in the long-term treatment. Lithium is not used in acute attack of mania because lithium is a slow-acting drug. So it's not used in the acute attack. Lithium is only used for maintenance, discharge time. Okay. So it's a mood stabilizer, controls both depression also, mania also. That's why we called it as mood stabilizer. Next, now that we have said this thing, coming to the side effects of lithium, there is a mnemonic here called lithium itself. Okay, the mnemonic itself is called what? Lithium. So you and I must simply know something. This is the mnemonic you got to memorize. They love to ask questions on this. You must know why it is avoided in the pregnancy, because it causes Epstein's anomaly, right? It is causing Epstein's anomaly. So that's it. It is a classical example of the drugs with low TI. What is low TI? Therapeutic index. See, what is therapeutic index? Quickly, let's recall. We give certain dose to treat a disease, that is the clinical dose, right? And then if that dose by mistake is given too much, there could be toxicity. The more the gap between these two, the safer the drug is, right? Clinical dose and toxic dose, if it is far apart, it's a safe drug, because even if you take 1, 2 extra medicines, you will not get a toxicity. Drugs like this, clinical dose and toxic dose are very near. That means this is going to be a dangerous drug, because little increase in the dose could end up in a toxicity, right? Little increase could lead to toxicity. So this is the simple logic right here. Okay. Now, since we have mentioned this, the next part is antipsychotics. Okay. Next one in the list, something called as antipsychotics. Now, what is the story of antipsychotic medication? See, you must know the aim of the treatment in psychosis is to block dopamine. We want to reduce dopamine. And reducing dopamine can cause Parkinson-like diseases, right? In fact, there is a group of diseases that we get, or side effects we get, called EPS. Reducing the dopamine will cause this side effect. Okay. So you must know an example here called haloperidol, aripiprazole, risperidone, clozapine, olanzapine. These certain medicines, you got to keep an eye on this, my friends. Okay. So now what I'm telling you is simply this. Uh, Clozapine is the drug used for resistant schizophrenia. Now, if at all they're going to ask you a question in this, almost every exam we are having a question on this table. Every exam, I'm saying. Last FMG, before that, every time. So these are things called EPS, extrapyramidal side effects. We get the side effects with high potency drugs like risperidone or haloperidol. So if examiner asks you who's causing this table side effects, then you should say either haloperidol or risperidone. Okay, haloperidol or risperidone, they are causing this. Okay. Next, on contrary, what they can do, they can ask you, if the side effects happen like this, what do you do? Do you stop this medicines who are causing this problem? The answer is no. We will continue the same medication which is causing this side effect. But what I will do, instead of stopping this medicine, I will treat this side effect. I will treat this side effect. So you got muscular dystonia, drug-induced Parkinson, etc., etc. So what I'm doing is I'm going to treat this side effect. Did you understand this? Okay. Neuroleptic malignant syndrome, NMS, etc. So this is the logic right here. So, sir, what do you give for the first two? That is muscular dystonia and this. You're going to give the drugs called Park-Your Benz drugs. That is benztropine, benzhexol. For akathisia, we are giving beta blocker. Okay. For neuroleptic malignant syndrome or malignant hyperthermia, same drug called dantrolene is given. Okay. Why is it called malignant? Malignant means something serious. Malignant means something serious. It is a hyperthermia. It is a hyperthermia. Okay. So understand this. If I hijack your ryanodine receptor, then I will be able to control calcium. If calcium is controlled, I can make you contract your muscle. Contractions will increase temperature. So what is happening when you give drugs called psychosis drugs? They hijack the ryanodine receptor. Or when you give some anesthetic drugs like halothane, succinylcholine, they also can hijack this receptor, ryanodine receptor. And what happens due to this is simply there will be too much temperature increase leading to deaths also. It's a very dangerous situation. So that's where what do you do in the treatment? Block the source, block the ryanodine receptor by a drug called dantrolene. So this drug will block ryanodine receptor, hence useful in malignant hypothermia as well as neuroleptic malignant syndrome. So this is it. Now, in this topic, low potency drugs like thioridazine, etc., what they do, okay, they will block ham once again, something we studied 5-10 minutes back. Okay, they block ham receptors. Now that we wrote this, the most common drug to cause hyperprolactinemia is risperidone. Okay, this is the most common drug to do this. This example is risperidone. Cool. Let's take a small break of 20 minutes, and after this, we will get back and continue with the remaining story. All right. All right, friends, welcome back again. So now let us continue. We're looking at something called anti-Parkinson drugs. Okay. So you must understand first what is the aim of the treatment in Parkinson. We want to increase dopamine. We want to increase dopamine. So how is this possible? We give a drug called levodopa, which converts to dopamine, right? So it's a precursor of dopamine. Now you must understand this line in center is the blood-brain barrier. I don't want levodopa to convert to dopamine in the periphery. So I will stop this conversion by a drug called carbidopa. So when I give carbidopa along with levodopa, levodopa will not convert to dopamine in the periphery. Now this levodopa can actually go into the brain, right? So this levodopa has gotten into the brain. And now this guy can actually convert to dopamine. And this is what I wanted. Same to same. Yes or no? But this I allow because I want dopamine in the brain. And this dopamine will work on a receptor called D2 receptor, which will treat Parkinson. This is the simple logic right here. That's it. So this levodopa converts to dopamine and this dopamine works on D2 receptor. Done. Now that we have said this thing, this dopamine could also be broken down by enzymes like MAO or COMT. That's why we got some other drugs like MAO inhibitors and COMT inhibitors, right? So two drugs we got here, MAO inhibitors and COMT inhibitors. So COMT inhibitor is a drug by the name of Capo. MAO inhibitor are the drugs like Gelin, okay? Next is the drugs called D2 agonist. Now, what does the word D2 agonist means to us? D2 agonist simply means these are the drugs that stimulate the dopamine receptor directly. Okay, this is what is happening over here. So, sir, D2 agonist, we got someone like ergots and non-ergot drugs. So, in the ergot derivatives, we have examples like, cabergoline and bromocriptine, cabergoline and bromocriptine. These are the examples you're able to see here, cabergoline and bromocriptine. What we should understand is there is one relation that says that if dopamine levels are increased or if dopamine activity is increased, then prolactin levels will be suppressed, opposite. Okay. So since we are stimulating the dopaminergic activity in the Parkinson, it can reduce prolactin. Hence, it is used in the treatment of hyperprolactinemia. Cabergoline is the drug of choice. Bromocriptine is the drug of choice in pregnancy for treating hyperprolactinemia. Next, the non-ergot derivatives. Okay, the non-ergot derivatives like pramipexole, ropinirole, rotigotine, etc. They are going to be used in the treatment of Parkinson's. Okay. Next, there is something called drug-induced Parkinson. So in the drug-induced Parkinson, what we use is the drugs called Parcure-Bens. They are the best medicines to treat this. Earlier, we used to use one antiviral drug called as amantadine. We don't use it anymore because we got better drugs. Why would we use unnecessary drugs when we have good drugs now? Okay, so it causes one thing called libido reticularis. Libido reticularis. Now, when it comes to Alzheimer's disease treatment, you must all know, as usual, we have already learned this. What we can add up to what we already learned before is there is a guy called beta amyloid that damages your brain, which is causing Alzheimer's disease. So we can block this bad guy. So we got some monoclonals who can do that. I gave you a mnemonic if you see that. Alzheimer's disease is the mnemonic, right? So that's how we are going to remember them. Alzheimer's disease, AL for Alzheimer, D for disease. Okay. Now, since we have gotten that, these are like less as disease, doesn't matter. Smoking. If you want to quit smoking, then you need to take a replacement of nicotine. Why? Because If you don't do that, if you suddenly quit smoking, you will get something called withdrawal symptoms. Now, to control those withdrawal symptoms, we can take nicotine replacement. The best replacement is nicotine inhalers. And if you talk about the drugs, then nicotinic agonist, they are the best drugs. What are they? Varenicline. Okay, varenicline, this is your medicine right here. Now coming to the topic called opioids. So sir, in the opioids, what they ask, I'm going to cover that only directly. That is this part. Okay, antagonist part. So you must know, when do I want to block mu receptor? When the mu receptor is working too much. That's where I want to do this, yes or no? That means mu receptor toxicity is opioid toxicity, because opioid drugs work on a receptor called mu. So if they are taken too much in amounts for abuse, obviously for enjoyment purpose, mu receptor gives you some things, right? Sedation, euphoria, etc. So for enjoyment purpose, if you have taken too much of opioid, so you have too much activity of mu. What do I do in the treatment? Block the mu. Okay. So what are these medicines that we must keep in mind? Let's try to understand. One is IV naloxone, that is the drug of choice. IV naloxone is the drug of choice. Later on, we may give oral naltrexone in this patient. Okay. Now comes alcohol. Now first, whether you drink ethanol or methanol, these byproducts can only come if this enzyme is working, called alcohol dehydrogenase. This is the name of enzyme. Now you must know, methanol is the one that kills you. And if you have drank this alcohol by mistake, that is methanol, you will get this byproducts, and these byproducts will kill you. They are the killers. Okay. So what we aim to do if somebody has drank methanol is, I want to somehow block this enzyme. If I block this enzyme, obviously this methanol cannot convert to the children. This metabolites, if they're not produced, you will not die. So that's what we do. Previously for this, we used to give ethanol. Remember, methanol treatment was treated by ethanol. But now we give something else, a drug called fomepizole. Okay, the drug of choice for this is called as fomepizole. That is the antidote for methanol toxicity. Next, for withdrawals, that means if somebody suddenly quit drinking and they're having withdrawals, then we give benzodiazepines, especially somebody called chlordiazepoxide, as it is a long-acting drug. If you want to quit drinking, then I give you a drug called disulfiram. What is disulfiram? A drug like a punishment. What does this drug do? If you drink alcohol while taking this drug, then you will fall sick because it gives you all the symptoms mentioned here. So it happens only if you take the drug and drink alcohol, right? This reaction will only happen then. So it's like a punishment drug. I told you, remember it by the name of God, right? It has the name of God in it, right? So if you take the name of God and you drink alcohol, which is a bad thing, you will be punished. That's how we had memorized it. Some drugs copy the same thing as disulfiram. It is called disulfiram-like reaction. Okay. So what are these drugs who do it? Metronidazole, cephalosporin. These are the antibiotics who do this. Okay. Now that we have said this, after this we can move to the next part called hemat. So one thing is very straightforward, sir. Iron forming drugs. I know you know this topic decently enough. If you want to absorb more iron, you need more acid. That's why you give it with ascorbic acid. And if you take PPIs, alkali, or anything, they will reduce the acid. Since there is less acid, there will be less iron absorption. And you should not drink tea with iron, because tea contains substances like tannates, etc., that also reduces iron. Now, if you're having too much iron in the body, exactly opposite situation. Reduce it by something called desferoxamine or deferoxamine. D means remove, Fer means iron. That's how you're going to remove it. So what is the antidote for iron toxicity, if anybody say? Desferoxamine. Next is a drug called British anti-lucite, BAL, used for BAL. Simple. Bal is used for bal. What is bal? Bismuth, arsenic, and lead. Done. Next, we talked about the folate, B12, etc. That's what we can see. This part, you can expect a question, sir. RBC, WBC, and platelets, how to increase. RBC you want to increase, you got somebody called erythropoietin alpha or erythropoietin beta. These are the drugs. Darbepoetin is sounding just like erythropoietin, that drug. Platelets, if you want to increase, you have a name here. If you check thrombopac, thrombocyte agonist. Thrombocyte agonist, those are the drugs. And WBC, if you want to increase, we know these names like GM-CSF, granulocyte, monocyte, colony stimulating factors, right? So these are the names like GM-CSF. So nice names. Gramostim means granulocyte, MO for monocyte, stim for stimulation. GM-CSF means granulocyte, monocyte stimulation. And we got grastims. What is grastim? Granulocyte stimulation. Okay. Now from this, since we have done, you can see a quick review right here. Anti-platelet drugs, meaning they don't allow the platelets to do this. If platelets don't come in an area where there is injury, it will lead to bleeding. So antiplatelet or anticoagulant, if this clots or this platelets don't come in the injured area, it will lead to bleeding as a side effect of all these drugs. Okay, now that we said this, try and understand. Antiplatelet drugs are better for arterial thrombi like MI, stroke, etc. The main drugs being aspirin or clopidogrel. Anticoagulant means they are better for venous thrombosis. Example drugs like warfarin, heparin. Okay. So antiplatelets may just make sure you know these two definitively. That is thromboxane A2 inhibitor called aspirin, ADP inhibitor called as clopidogrel. Clopidogrel. Okay. So this is it. And I told you one interaction, omeprazole should not be given with clopidogrel. Otherwise, the drug clopidogrel will not get active because it inhibits one enzyme. What enzyme does it inhibit? CYP2C19. Yes or no? That enzyme is simply known as CYP2C19. So that is the simplest thing right here. Okay. Now that we are done with this, sir, this topic is very, very important. That is anticoagulants. Okay. Anticoagulants. Now, if you talk about this, anticoagulants. So the thing is, this is the coagulation pathway. Now, if you talk about the coagulation pathway, this is the simple story here. There is conversion of something called fibrinogen to fibrin. And fibrin is nothing but what your clot is made up of. So for this one step to happen, you can see there is the whole pathways here called extrinsic and the intrinsic. So what I'm telling you simply is this, extrinsic or intrinsic pathways. If you don't allow this pathway to happen, let's say you block at some step, this will not happen, meaning everything will be blocked. Clot will not form. Anticoagulants, they will block something in this pathways. Okay. Now there are two types of drugs in this topic. Direct drug. What do you mean by a direct drug is this drug will come directly work on some number and block it. Next, there is indirect. What do you mean by indirect? There will be a drug that works here. The drug works here on this. This eventually works on this pathway that is called indirect. So as I said, we got two things here. One is direct, another is indirect. Done. Let's move into the topics. Vitamin K inhibitor. Vitamin K inhibitor is a medicine by the name of warfarin. Okay. Vitamin K inhibitor is a medicine that is called warfarin. This is used for, you know, this is a drug that is used for venous thrombosis. Okay. It can be used for DVT, it can be used for everything, but it's mainly preferred for people having mechanical valves in their heart. And I told you, you need to maintain this INR of 2.5 to 3.5. Okay. This is about warfarin. Next is if we talk about the drugs called DOACs. Okay. DOACs. These are the drugs that we generally prefer for the treatment these days. Okay, these are the drugs that we are preferring for the treatment these days. For what? For the DVT, etc. Warfarin can also be used. They also can be used, but the preferred ones are DOACs. Please remember, oral drugs are only good for maintenance or prophylaxis. But the same disease like DVT, if you come to me in the hospital, I'll give you heparin. Heparin is an injection. Okay, heparin is an injection. Now, if we move further in this, the drugs in this topic are called Exabans and dabigatran. Okay, Exabans and dabigatran. Next is injections. In the injections, we got heparins, low molecular weight heparin. So they are all having parin in the name. Okay, they're all having parins. Now that this part is done, this is a table you must keep an eye on because anticoagulants, say one question is almost compulsory in your exam. They love to ask this topic. So heparin, warfarin. Heparin is used in hospital, warfarin is used for maintenance. So if you check your notes, I told you that warfarin, the target INR to be maintained is 2 to 3. Okay, 2 to 3. So what we must get is if the INR is increasing more than 3, okay, unless it's a mechanical valve patient, until 3.5, it is acceptable to be normal. But if it is DVT or somebody else, 3 to 10 is like a higher dose. So what you should do, start at a lower dose. If the value is becoming more than 10, then there is too much, give antidote. In fact, if there is active bleeding at any INR, if there is bleeding happening, you should give antidote. That is the simple logic any doctor should have. Pregnancy, I made you write it clearly. I don't need to explain, hopefully. Antidote. Protamine sulfate is the antidote for heparin, whereas vitamin K is the antidote for warfarin. All right. Now, after this, we got something called fibrinolytic or thrombolytic agents. Okay, fibrinolytic or thrombolytic agents. So, what is the story of fibrinolytic or thrombolytic agents? See, they break clots. How do they break clots? So, this is my clot, which is made up of fibrin. They break it with the help of plasmin. Plasmin breaks the clots. Plasmin comes from plasminogen. So these drugs all stimulate the plasmin directly, indirectly, whatever. Two drugs, streptokinase and TPase, they are having place in the name. Okay, altiplase, dutyplase, etc. They're going to have what in the name? Place. Okay. Now that this part is done, Next is once again a very important topic for exam, that is diabetes mellitus. Now you must remember that in diabetes we give insulin as a medicine which works through something called tyrosine kinase receptors. Okay. Usually speaking, the insulins are given by subcutaneous route. One of the insulin that is given IV is regular insulin. Because it's given IV, it is useful in emergency called DKA, diabetic ketoacidosis. I told you new insulin has come called Afrezza. It is a inhalational insulin. It's a new insulin called inhalational insulin. Okay, this one is very fast acting because if you inhale it, it will be quickly absorbed in the lungs. It's very fast, but it is short acting, very, very short acting. Okay. Next, if you move further, insulin can cause hypoglycemia as a side effect. It's a logical thing to understand. The rapid insulins have maximum chances of hypoglycemia. Why? Because they suddenly get absorbed this much in the blood. That's why they can cause hypoglycemia more easily. Since these three are having some peaks, they all can cause hypoglycemia. Long acting insulin, because they don't have a peak, they are like this. They are called peakless insulins. Long acting are called peakless. And as you see here, they are having least risk of hypoglycemia. So you should see the names, which one is long, which one is rapid, etc. Okay. Now coming to anti-diabetic agents, where usually the question will come from. Okay. Now, in this diabetes topic, you must remember that there are some drugs who can make you release insulin. So, what are these drugs that can make you release insulin? They're called insulin secretagogues. They increase the secretion and hence they're called secretagogues. Okay. Now that you see this, if you block this potassium channel here, potassium cannot go out of the cell. So it increases in the cell. The positive ions increasing is called depolarization. Depolarization causes contraction of the vesicles, releasing more insulin. So anyway, that is the mechanism. You need to block the potassium channels, inhibit the potassium channel. This will lead to that. Now, these drugs are very commonly used drugs. IED is in their name. Take that as a mnemonic. I decrease glucose, meaning they will cause hypoglycemia. Amongst the oral drugs, if they ask you which one cause hypoglycemia, then your answer should be sulfonylureas. All right, they are increasing insulin. Now, there are some other guys that will also increase insulin, like GLP-1 agonist. GLP-1 agonist are drugs like glutide, right? Remember this, dulaglutide, etc. Semaglutide, dulaglutide. I hope without me saying this, you can see the mnemonic and remember what we said. Okay, semaglutide. Why do you remember sema? Do you remember? You are the one sema. We wrote one mnemonic there. So weight loss. You should know these are the drugs for the weight loss. Next is your DPP-4 inhibitors, that are the drugs called gliptins. Gliptins. So when you talk about the gliptins, the idea is that most of them are removed by kidney. So they should be avoided in renal failure, or if you want to use them, you need to reduce their doses. Because if your kidneys are bad, don't give drugs that come out of kidney. You can give them a drug which is linagliptin, which is not excreted via kidney. Just to remember, we say L for lina, N for liver. So this drug is excreted by liver, hence it's safe in renal failure. Okay, so this is what you need to know. For renal failure patient, we need to take a drug called linagliptin. Next comes your metformin, right? This is a drug called as metformin. Metformin, apart from your diabetes, it's also used in PCOS patient. Now I told you PCOS patient treatment depends on what does the patient want. If you're talking infertility, the treatment of PCOS is going to be something else. Infertility is treated by a drug called letrozole. If you want to treat the other symptoms of PCOS that is there, then you need to give OCP, and diabetes, that is the resistance. If it has happened, then I'm going to give you a drug called, metformin. So this is the logic here. Next is glitazone type of drugs. This one works on something called PPAR gamma, increasing the receptors called GLUT4 receptors. Okay, increasing something known as GLUT4 receptors. As we have mentioned this. Okay, now you can keep an idea. I told you these are the gamma type of personalities. They break your heart. Remember, better you avoid them in the heart failure. Okay, so these guys, gammas, they break your heart, they break your bones. So that's how you have to remember them. The girl whose heart was broken, Rosie. So gammas broke the heart of Rosie. So Rosie glitazone, this is the medicine in this topic. And do keep an eye on this part, sir. Which drugs are safe in heart patients, renal failure expected? See, anyway, in this topic, the more you study, the safer you will be, because some question will come for sure from diabetes, etc. Now we know from GIT, when I have eaten something, glucose, will come into my bloodstream, and the enzyme that helps it to do so is called alpha glucosidase. So if you block alpha glucosidase right now here, you will not get sugar in your blood. You know there are drugs called as acarbose, absence of carbs when you take this drug. So that's how you're going to remember acarbose is absence of carbs. Done? Next, now that we said this, when you take these drugs, you know, they will cause GIT side effects. This is an enzyme in the GIT. GIT side effects will come, gases and diarrhea. SGLT2 inhibitors, they are the drugs called gliflozins. Okay, they are the drugs simply known as what? Gliflozin. So these are the drugs, mnemonic glucose flows in urine, what we learned. They work in the kidney. Because they work in the kidney, they make you lose glucose through the kidney. Glucose flows in urine. You get UTI and genital infections. And you must also know that these drugs are approved for CHF. In the recent exams, I told you this has been repeated many times. Maybe again they will repeat this question. Keep an eye on the gliflozin topic, please. Okay. So now that we have discussed this, anti-thyroid drugs. So we are talking about treating thyroid problems, anti-thyroid drugs. So if you want to reduce the thyroid hormones in a patient having too much, called hyperthyroidism, block the enzyme that produces thyroid hormones, and that is thyroid peroxidase inhibitors. They will reduce the thyroid hormone. Usually what they ask in this topic will focus on that, my friends. See, if a pregnant woman is having hyperthyroidism, first trimester we must give that woman propyl thiouracil. Second and third trimester we may go for methimazole or carbimazole. Okay. If you give the drug methimazole, carbimazole in the first trimester, the child will get this esophageal atresia. Okay, I hope you guys understand this esophageal atresia. Did you all understand that? Done. Next, now that this is done, replacement. If somebody is a hyperthyroid patient, we give methimazole, carbimazole. If somebody is a hypothyroid patient, then the drug of choice becomes levothyroxine. Okay, this becomes your levothyroxine. So that is the simple logic right here when it comes to this topic. Done? Now, next coming to the bone, the main drugs in the bone topic, it is nothing but your bisphosphonates. Now you may check this out. The drugs called bisphosphonates happen to be the drug of choice. They happen to be the drug of choice. They are called dronates. They are the drug of choice for the treatment of osteoporosis. Okay, they are the treatment of choice for your osteoporosis due to any reason. I told you that they need to be, discontinued in between for some time, then continue again. If you continuously give them, they can actually lead to increased risk of bone fractures. Okay, they can increase the risk of bone fracture. The cautions to be taken with these drugs, drink water, sit straight for some time, they will be tested in exam. So simple osteoporosis you want to treat. My drugs bisphosphonate will block the osteoclastic action. Meaning if osteoclast will not break the bone, then that's how I'm treating osteoporosis. Only one or two drugs can stimulate osteoblast activity. Example, teriparatide. Okay, teriparatide, it is a drug from parathormone topic that can actually help in the bone formation. Clear enough all? Okay. Now, since we have learned this, drugs working in the reproductive system. Now, I told you there are two drugs called relin and relix. In this topic, they work on the releasing hormone. Releasing hormone, hence they are having rel in the name. Rel means releasing hormone drugs. Okay. Now, hopefully, from your gynecology and our previous discussions in pharma, you may remember these drugs, if you give them in a pulsatile dose, they can stimulate the functions. And if you give them in continuous dose, they will produce blocking function. Relins can be given pulsatile also as well as continuous, whereas these drugs can be only given continuous. So what it means, they can only produce blocking effects, whereas these drugs can produce both blocking as well as stimulatory effect. Now in this page exactly, you should be able to see where is pulsatile dose given. Pulsatile dose meaning to stimulate this function, we will give pulsatile dose, and this is useful in some puberty. Which puberty? Delayed puberty and in infertility. Whereas most of the other problems, we need to give continuous dose. Okay. So that's all about this relin and relix. Next comes this SERMs. What is the story of SERMs that you must keep in mind? Okay. So when you talk about the SERMs, the idea is simply that estrogen is only working as an agonist everywhere, which is not a good idea. The only good thing that will come from this is treatment of osteoporosis. All this will be bad because breast cancer risk will increase, uterine cancer risk will increase, all this will be bad. Now, to overcome this problem, we created drugs called SERMs like tamoxifen and raloxifene. So you can just see where they stimulate, where do they block. Now, a way to remember them is they all can treat osteoporosis, which is a good thing with all the three drugs. They all can cause thrombosis side effect. That means it's a bad effect with all. The only difference that will come is breast and uterus. Raloxifene is good in both. Tamoxifen is good only in the breast. And finally, estrogen is bad in both. Okay, I hope you guys understood this. They are having one good effect, one bad effect, all of them. Only difference comes in which tissue, breast and uterus. Who is good in both? Raloxifene. Good only in one, tamoxifen. Good in none, that is your estrogen. That's your cell. So tamoxifen happens to be the drug of choice for the breast cancer. Okay. Now coming to the drugs that are used in infertility treatment. One is clomiphene citrate. Another is, letrozole. Letrozole is preferred for PCOS-induced anovulation, and it's also preferred for postmenopausal breast cancer. Postmenopausal breast cancer. Fine. Next comes contraception. See, this anyway you study in your OBG as well. As a quick reminder, less than 3 days, less than 5 days, if they ask you what is the best contraception method, your answer should be intrauterine contraceptive devices like copper T. Okay, sometimes the problem comes, if some other subject, things they will ask in relation with pharma. With drugs, I told you my best drug up till 3 days is LNG, that is levonorgestrel. Ulipristal up till 5 days. After 5 days, you don't have good effects. So in this 3 days, 5 days, whatever, if they ask what is the best thing, it is copper T. Okay. Abortion drugs, mifepristone, misoprostol. I want to do abortion. First, block progesterone because it is the hormone maintaining pregnancy. So mifepristone, misoprostol. Once you have blocked progesterone, now you can induce the uterine contractions by giving misoprostol. Okay, so I told you the doses and everything. Just make sure you memorize that. Coming to anti-androgens. In the anti-androgens, specifically, this topic will be very high. 5-alpha reductase inhibitor. Okay, 5-alpha reductase inhibitor, somebody known as finasteride. So if you talk about finasteride, this is the guy that is used for the treatment of BPH. What is the purpose of using this drug in BPH? The answer is it will reduce the size of the prostate. Why? Because if you block this enzyme, the size of prostate will reduce and hair loss will also reduce. That's your anti-androgen. Okay. Next, oxytocin is given for induction of labor. I think it's a very basic point for you now, right? And uterine relaxants like nifedipine is given for preterm labor, okay, premature labor. When it comes to growth hormone, make sure you remember these drugs, please. One is pegvisomant, ANT for antagonist of SOM. SOM means somatotropin, which is growth hormone. Growth hormone antagonist is given in acromegaly. Although it is used, it's not the drug of choice. The drug of choice for acromegaly, it will be somatostatin stimulator drugs like octreotide, lanreotide, etc. Okay, the drug of choice is this. Now, somatostatin, I told you it's like a class monitor, right? This guy, somatostatin, is like a class monitor. So I want you to know that it is reducing the other guys, hence its use. It will inhibit something mostly. It's inhibiting the diarrhea. It will be useful in certain diarrheas, called secretory diarrheas because they're due to some cancers or some tumors. It is a drug we use in esophageal varices, but the main treatment of esophageal varices is nothing but terlipressin. Okay. Next is steroids. The most important question in steroid is this. So when you will be watching the 25 important question, you will see this. Anyway, I gave you the hints how to remember. D is the fourth letter. P is the second letter. So if you have to give 24 mg in 4 divided doses, each dose has to be 6 mg. If you have to give 24 mg in 2 doses, then each dose must be 12 mg. That's all pretty straightforward. 48 hours means 2 days, if you keep roughly 2 days in mind. If you have to give 4 doses total in 2 days, don't you think each dose should be given at half a day, 12 hours? And if you have to give only 2 doses total, it will be given in what? Every 24 hours. That's it. Next is autocoids chapter. Now in the autocoids, the basic idea, this is what it will be. Histamine, antihistaminics. Since histamine is blocked by these medicines, they can cause sedation. Since they are blocking this, they can treat allergies. So there are two types of antihistaminics I told you. First generation who cause sedation. second generations who don't cause sedation or they cause less sedation. So you must remember the first generations are very, sedative drugs, they are highly sedative drugs. Second generation, if you compare, they are less sedatives. Now, in this less sedative, who produces more sedation? Cetirizine. Cetirizine is the least, in the second generation. But if you see, it is producing good amount of sedation, although it is in the second. Who's the least sedative drug? It is fexofenadine. This is important for exam. Fexofenadine is the least sedative drug from this topic. Okay. Now that you see this, next is serotonin. In the serotonin topic, okay, one drug is cetrons, 5-HT3 blockers. They reduce vomiting because 5-HT3 causes vomiting as a function. Okay, so I am saying when you block 5-HT3 receptor, these are the drugs called cetrons. They are the anti-emetic drugs. The most important high yield topic in serotonin, in fact, in this chapter is migraine, which I want you to look in the 25 important question series and learn. I'm forcing you to watch it for a reason because that way you will cover it. When I said it's important, it may be coming in the exam because it's almost there. You will at least watch it. Don't delay. When I said something, do it please. After listening to this quick revision and everything, many things get brushed up in our head. You need to give one more reading quickly and then look into those questions. Or again, you look into the 25 important question videos quickly. At 2x speed, you can keep skipping, right? Some things, if you know already, skip, right? So if you don't know, look at that, hear me out, what I'm saying there. Then you go and revise the notes. You will feel much easier because you will already know many of the things. Then take the exam, and soon enough, we'll be again seeing each other in the TND, right? That's the game plan. You all can do it. I know this is the time you doubt yourself. We feel low. We start thinking, am I going to crack this? Right? Especially if you're repeating, this thought comes much frequently. But again, all these things, you need to keep aside because the person in the end who needs to fight is you, my friend. Okay? Because unfortunately, this is the brutal truth of the world that motivations and everything work for some time. You hear somebody saying some nice words, you'll feel better for some time. Then you go back, sit with the books, again, you'll feel low. So you need to man up. Tell yourself that whatever the hell this is, I'm going to do it. Right? That is the self motivation. Right? Anything that gives you that kick. It may be different for different people. Right? Imagine if you are a person, if you have that vision that I want to show my parents white apron. I will be in a hospital. Maybe my father, mother will come to my hospital. They will see I'm sitting on a chair. People are waiting in line to look at me, so that I am that doctor they want to see. So tomorrow you will be that one. And for that, you need to work hard. Nothing comes easy. In fact, the only thing that requires motivation is study, sir. Remaining things, we just get it done. I don't need to motivate you to do anything else. This is the only thing. And for this, whether we like it or not, we need to take that, pill. So I am simply saying that sit. If that is the case, keep the wallpaper of your parents. You, you know, are a very religious person or something, you know, tell that whatever it is, like this is God, please help me. Keep the wallpaper of the God, keep looking at that and say, God, I'm doing my hard work. Please bless me for my hard work. All right. So that is one thing. Anything that motivates you. You have a girlfriend or a boyfriend, that person is going to get married to somebody else. In case you don't pass this exam, do it. Okay. Pass this quickly. Don't be like that Bollywood drama where you're like, Tukra ke mera pyar mera intikam dekhegi. That girl is gone. What is the, story of intakam now. Okay. Be in the moment rather than taking the revenge later away. Right. So this is all I'm saying. Anything that motivates you, do that and get back to studies. All right. Slap yourself if your brain is going here and there. Slap it, come back. All right. Are you getting that? So this is the topic migraine you will do from that videos. Okay, trust me. And if you watch all the 4 videos, 4, 5, whatever is there, it will take some time, but trust me, you'll cover a major aspect of important aspects of pharma. You keep asking, sir, if I'm not so good, what should I study? Watch 25 important. That is what is important. Again, in that, what is important, don't keep asking, right? You're not giving exam to me, sir. You're giving the exam for the board. They may give you anything. We are trying to help you. Okay. Many people message me, sir, if I only read what you underline, that will be okay now. Who are you pacifying? Who are you satisfying? Just if you tell me, are you feeling better? That okay, I did my part. What if the question comes from the other thing in exam? So be real, be real. I'm not a person who always keeps pacifying, it will be okay. I tell you, it will be okay if you work for it. That is the simple thing, sir. That's the reality of life. If every time you keep hearing it's going to be okay, then everything would have been okay for everyone in the world. Life is not, that, great for everyone. Be thankful to God that you are in some position where many people dream to be, right? Let's man up. Let's face that reality. You are in the cream of the society. Doctor oh bhai, one of the only profession where people call you by your profession name. Doc Saab, I used to call you by that name in the class. Remember this? That is the profession. So I'm just saying, not everybody has that, luxury. Not everybody gets called by that. You may be a very rich person. You might be an industrialist. Nobody calls you industrialist and your name. They will just say Mr. So and so. Okay, Mr. Ambani, Mr. Adani. They may be owning everything in the world, but still they're Mr. So and so. But you, my friend, you might be earning 10,000 rupees, but you're called doctor. Okay? This is the respect we'll get. So that's fair, right? Be grateful for where you are, be thankful, and be like, I'm going to do it. Until now, you passed every exam, ye bhi hoga. Maybe one attempt, maybe two attempt, whatever it is, I will do it. Have that kind of attitude. Okay, don't wait for somebody from outside to tell you every time, like, study, study, you will be okay. That hope that you're keeping with somebody else, that will break you, because nobody is sitting with you 24/7. No? Why do we expect it like that? For some time, it's okay. Okay, once in a while, yes, I'm feeling bad. Somebody tells me it's all right, man, you can do it. That is okay. But every time waiting for that thing, then you have to, check, are you on the right track? Okay. So, anyway, coming back, beta blockers and everything done. Now we are on the topic. You hopefully can see this. This is the pathway of inflammation. Yes, prostaglandins, they will increase inflammation. This is what we must know. They increase inflammation, pain, fever. So there are drugs that can stimulate prostaglandins. They are called prost drugs, letanoprost, carboprost, etc. Then there are some drugs that will block them. They will reduce inflammation. They are called NSAIDs, anti-inflammatory drugs. Why are they called non-steroidal anti-inflammatory? Because they're reducing inflammation. There are some other drugs who also reduce inflammation. And who are these ones, sir? They are nothing but, the drugs that are called steroids. So one is steroids, another is, this guy called NSAIDs. They both do that. Now, since we all know this, leukotrienes, there are some things called leukotrienes. So leukotriene, they will cause bronchoconstriction. Leukotrienes, they will cause bronchoconstriction. So if you block leukotrienes somehow, then bronchoconstriction will not happen. We got drugs called xyluton. Okay, look at the name of the medicine. xylutone, that means I have a LEU word here, leukotriene. And we got the drugs called Lucast. Again, I got LEU, Montelukast, Zafilukast. Clear? Now, since we mentioned this, now you can have a look here. Prostaglandin E1. This is a drug we already mentioned called misoprostol. Okay, misoprostol. This is a drug that is given in the treatment of peptic ulcer disease. Next is this topic, very, very important, that is prostaglandin. See, I'm not even talking abortion because we already discussed misoprostol is used in abortion. PGF2 alpha. Now we got drugs like latanoprost, bimatoprost, etc. in this topic. Now tell me something, doctors. Don't you see a mnemonic written over there, PGF2 alpha? So when you see that PGF2 alpha, you must know all those, side effects, good effects with those drugs. Okay. Next, coming to the topic known as NSAIDs. So what is the story of NSAIDs? Non-steroidal anti-inflammatory medications. Now you must keep in mind some basic distinction here. Blocking the COX-1 will cause a side effect called peptic ulcer disease. So if you block this number, you will get peptic ulcer. So that's why we decided the new drugs we made, we will not block that. They're COX-2 inhibitors. Now the COX-2 inhibitors are called COXIBs. Okay, the COX-2 inhibitors are known as COXIBs. Okay, what is COXIB? COX inhibitors. COX inhibitors. The most repeated topic from this is paracetamol. Please remember, what did I teach you about paracetamol? The toxicity aspect especially is very high yield for you. So if you talk about the toxicity, paracetamol toxicity, that is a very high yield thing. Now, ladies and gentlemen, this drug at high doses, it causes hepatotoxicity. 4 gram is maximum dose what we give in the practice. But usually the toxicity is seen at 10 grams and above. Are you understanding what I'm saying? What we give, it's enough for us to give 4 gram. We don't give more than that. But when you see toxicity is 10 grams and above usually. So I am saying that, so this drug is a wide spectrum, wide therapeutic index drug. It's a safe drug. Can we say that? Okay, it's a safe drug. Now, since we already mentioned this, have a good look. We got something called NAC here. What is NAC? N-acetylcysteine. This is the antidote, right? N-acetylcysteine, this is the antidote. Please make sure you remember, we need to block something called NAPQI. When you take too much of paracetamol, somebody called NAPQI increases. So what we do, we block this NAPQI by a drug called NAC. So the mnemonic I told you, NAC opposes NAP. That's how you must know this. Next drug is something called aspirin. Now, aspirin is the only drug from this topic. Apart from the NSAID, it's also an antiplatelet drug, which we learned in the previous chapter. Okay. Now, the next thing is that if you talk about this drug, it doesn't have an antidote. But if you see, it's coming from salicylic acid. It's a acidic drug. And did I teach you this before? If a drug is acidic, we remove it by opposite thing called alkaline diuresis. We saw it in barbiturate also, here also. Okay. Now this is just straight one-liners. Indomethacin is used in gout, etc. This you need to read on your own directly. Okay. Now, since we already learned peptic ulcer ka difference, which drugs do not cause peptic ulcer? The answer is COX-2 inhibitors. They don't cause peptic ulcer. And who causes peptic ulcer? The non-selective drugs. Okay. Now that we got this, next, again, an important topic called as gout. Okay. What do you do? If there is a case of acute gout, meaning already there is swelling in the, metatarsals, etc., that you're seeing first metatarsal usually. So you need to reduce the pain as of now. You can reduce the uric acid later, right? It's already there now. So first reduce the pain. Later we can go for reducing the uric acid. So indomethacin is usually the preferred drug in this situation. Okay. Now, if you talk about chronic gout, this is what they love to ask usually. Here, the aim of the treatment will be to reduce the uric acid. And how am I going to use this in the chronic gout? There's an enzyme called xanthine oxidase. If you block this enzyme, logically the uric acid will not be produced only, it will be reduced. So we got the drugs like allopurinol, purine in the name, and the second drug called febuxostat. I told you the drug of choice is allopurinol, and xanthine oxidase inhibitor, also called febuxostat, is used if allopurinol cannot be handled by the patient. Allopurinol allergy, we will go for a drug called febuxostat. Okay. Next is something called uricosuric drugs. Uricosuric means something that increases excretion of uric acid. Okay, there's a drug called probenecid. So it is a drug that will enhance the excretion of uric acid, probenecid. Okay, now that we've said this, last and the final, somebody who can break down the uric acid, it's called rasburicase. Okay, there is a medicine by the name of rasburicase. So when we see this drug called rasburicase, what you and I should know here is simply this. Doctors, this is used in a situation called as TLS, what is known as tumor lysis syndrome. Okay, rasburicase and one more, that is allopurinol. We use it in a situation called tumor lysis syndrome. So this is basically breaking down your uric acid. Okay. This rheumatoid arthritis, one or two things that are important in my opinion. One is hydroxychloroquine, the drug that we use as an immunomodulator in rheumatoid arthritis to control the inflammation or immunity. We give immunomodulator drugs. Hydroxychloroquine, it causes this thing called bullseye maculopathy. That side effect is something you got to know. Okay, bullseye maculopathy. Next, now that we saw this, all right, general pharma guys focus mostly on those things. See, when you're reading systemic pharma, many of those things you're going to get already. There are like 4 or 5 formulas that were there. You need to sit and memorize those formula. What is the formula of VD? VD is equal to D by C. You should know the formula. What is the formula for half-life? 0.693 times VD over clearance. So those formulas, you need to memorize it and do that. The main topic that you can expect from the general pharma in your exam is something called dose response curves. Which drug has maximum efficacy, maximum potency, all right, those questions alone. So this you will see in at least 3 videos of mine. Every time I post that because not everybody watches all the videos. Although I strongly suggest watching all the 4 or 5 videos. Why? Because each video will have some topic which may not be in the other video. So that's where you get to cover more ground. And if you're doing all the 5, some topics I've repeated in every video because it's asked so many times. So that way you get to memorize that topic more better. 4 times if you have done that question in my 25 important video, then you won't make a mistake in the real exam. That's it. That's the whole purpose. Okay. So that's where just watch that 25 important wala, do the DRC, clinical trials. Those are the 2 main things which I've already done there. Okay. So 2 things will be sorted for you from there. More or less, that is the part. Up coming to the anti-cancer drugs. Okay. Anti-cancer drugs. The idea is this. This is what is called cell cycle. Okay, this is what is known as cell cycle. So when you look at the cell cycle, if the cell cycle happens, then cells will multiply, cells multiplication will take place. And when the cell multiplication take place, it is going to lead to cancer, right? So what do anti-cancer drugs do? They will be blocking this cell cycle. Now there are two types of drugs. Some drugs block everywhere, but they may work little more on some places. They're called non-specific drugs. And the second is they work only in one part of the cycle. They're called specific drugs. Okay. So one type of a question that you're going to do here. Okay. One type of a question is simply this. You need to memorize this table right here that you can see. So what is in this table is the classification of anti-cancer drugs. So if you see platin in the name, it's a platinum drug, meaning cisplatin. All right. Antibiotics. Antibiotics will have mycin or rubicin in their name. Mycin or rubicin in their name. So these are the drugs that are non-specific, meaning they will work on all the phases of the cell cycle. Next, what are the specific drugs? Check. One is folate inhibitor, methotrexate. Methotrexate is a folate inhibitor. Purine. Purine means adenine and guanine. So you got drugs like 6-mercaptopurine, you got 6-thioguanine, azathioprine. So these drugs are all what? Purine drugs. Pyrimidine. What is pyrimidine, sir? The drugs which are, cytosine or uracil. Example, 5-fluorouracil. They will come in this. Next is M phase. M phase is vinca and taxane. Any drug having Vin is Vinca, Vincristin, Vinblastin. They work on M phase. Taxane, paclitaxel, docetaxel, they work on the M phase. So once you're done with this classification wala part, okay, classification is over. You know now how to recognize which drug works where. Second part, what I have done is anti-cancer drugs, they kill a lot of cells in the body now. So a lot of side effects will come. So those side effects, you need to know which drug causes which side effect and their antidotes if they are available. In the last 25 important question wala video, last one, the recent one, I have made sure that all students get this benefit. You don't have to do anything. I have discussed important side effects of anti-cancer along with the side effects. So that you do. Classification mechanism is over. Side effect is over. What remains is uses. So for the uses, I told you this is the table that you need to revise. And in this also, I gave you a trick that is majority places cisplatin can be the drug of choice, plus or minus 5 if you can see head till neck. The drug of choice is which one, sir? Cisplatin. Head and neck, the drug is cisplatin. Next is lungs, below the neck, lungs, cisplatin. GIT, cisplatin. Below that, urinary tract or genitourinary tumors, again cisplatin. Osteosarcoma, cisplatin. So everywhere it is almost cisplatin. I think everybody must have memorized tamoxifen and letrozole for breast cancer. This is over. तो बचते हैं few drugs here and there. You can give it an eye. Each day you can memorize one like that. You should be done with this. Okay, easy. Break it into parts. First time in this video, you learn classification and the uses. Then the second part, I told you side effects. Remember I said how to revise pharma? First only uses, next only side effects. Then later on one review you can give later in 1 month later. Because this is not enough. Your exam is still 50 days away. All this hard work you're doing, again you will forget if you don't revise. The whole aim of this revision video to be short, I am keeping is so that you can revise it multiple times. 10 hours also if I teach again, you will forget. That is the problem now. ठीक है, आज पढ़ लोगे, फिर अगेन यू विल फॉरगेट मेनी ऑफ द थिंग्स. दैट्स व्हाई इट शुड बी मोर रिवाइजेबल क्विकली टू जस्ट सी एंड ओके, ये बोला था सर ने. दैट इज द एम ऑफ दिस. ओके, now I hope you guys are comfortable. Anti-cancer 1 to 2 question. Most likely you should be able to answer from these things what I said if you do that. Okay, now comes the chemotherapy second part, that is antibiotics. The antibiotics mein first I'm going to do this part which is very high yield, the specific chemo. What do you mean by specific chemo? Specific chemo simply means those drugs which are given only in specific diseases or infection. They're not used other places. Example, you don't use HRZD anywhere else. Yes, HRZD is used only in the TB. So now I'm saying this, the treatment of TB, first 2 months you give HRZD. Next remaining months, you have to give HRE. HRE. All right. So I hope everybody got this idea. Remaining time, I'm going to give you only HRE. So in the TB topic, mainly you must know that the side effects of TB drugs is important. तो ये तो अच्छे से पढ़ लो. ठीक है, side effects. Then when it comes to isoniazid rifampicin, pretty much read everything. Okay. Why? Because TB, the cell wall is having something called mycolic acid. So who breaks into and breaches the cell wall? Isoniazid. It's important drug. RRR, I told you, rifampicin, RNA inhibitor, RPOB gene mutation, and red orange secretion. What is this RPOB gene mutation, etc.? Sir, this you learn in microbiology also, na? Okay, why doesn't this drug rifampicin isoniazid work? This guy mutates itself. Some mutation like CATG gene mutation, RPOB gene mutation, the drugs like isoniazid rifampicin will not work. Is that understood by everyone? Okay, this is done. Now, since you and I said that, what are more questions that you can expect from this topic? Sir, these definitions, you must know what is MDR, TB, pre-XDR, XDR. Now for the MDR, the new treatment that has come is called BPAM regimen. Keep an eye on this. Next is this, if a patient is having TB plus HIV. If a patient is having TB plus HIV, first we should always start the TB treatment followed by HIV sometime later. Otherwise, there is a risk of something called iris. What is iris, my friends? Iris is one inflammatory problem. Now, one more thing I'll discuss. Rifampicin is a drug. What it will do, it will increase the enzymes of metabolism. Okay. If you increase enzymes of metabolism, more drug will be metabolized quickly. Increased metabolism is happening, meaning the drugs will go out. So if you're giving rifampicin to somebody, it may increase metabolism of some drugs. Example, OCP, meaning it will lead to OCP failure because it's getting metabolized. Warfarin, HIV drugs. So what you should do is, example, HIV drug. You all know in HIV, we learned the treatment is called LTD, lamivudine, tenofovir, dolutegravir. From these three drugs, what will rifampicin do? It will fail your dolutegravir because it will go out of the body quickly. Metabolism will happen. It will go out. So it will fail your dolutegravir. So what do you do if you're giving rifampicin along with HIV treatment? You should double the dose of dolutegravir. D for double. Dolu, okay? We should double. We call this as dole na. We have two dole. So dole shole as they say. So dolutegravir mein double. We need to double the dose of dolutegravir. Clear? This is the interaction part we have learned. I told you rifampicin causes OCP failure. Rifampicin is causing dolutegravir failure. So that's why we need to double the dose of dolutegravir. Done. ये हो गया boss TB के main question. Leprosy kit I told you back then. Leprosy kit क्या होता है? Day 1 you have 3 drugs, rifampicin, dapsone and clofazimine. DRC. Remember this sequence only. D is the first letter in my mnemonic, only one drug. R is the second word, two drug. Rifampicin, three drugs. So this drug is only one, white one, dapsone. This is rifampicin. This is clofazimine. Are you understanding that? DRC, three drugs as I discussed right now. Now you can check. Rifampicin is given only once a month. You don't give it after that. The remaining month, you have to give only two drugs, which is dapsone and clofazimine. They are continued after this. Okay. Dose also, we will quickly continue. Dose if you talk about. So, ladies and gentlemen, initially dapsone is 100, later on also it is 100. Clofazimine, initially it is 100, later the dose is reduced to half, that is 50. That's it. This is the logic of this. Done. Next, if you talk about HIV, let me just tell you this. HIV, your question is going to come from this much area. 90% chance your question is going to be from here. I'll cover that only. So, first thing, pre-exposure prophylaxis. People who are having high risk of exposure to HIV, those people can take some prevention. Their prevention will be drugs called T and E. This is most commonly used. What is used is T and E. So what is T? T for tenofovir, E is emtricitabine. Okay, so what we generally use in prevention is T and E. All right. Now the newer drug that is existing here is called carbotegravir. Okay, carbotegravir. So now since we saw this thing here, carbotegravir, etc., this is about what? Pre-exposure prophylaxis. Now that we talked about this, sir, we can move into the next topic, that is post-exposure. Okay, next one is post-exposure prophylaxis. What do you mean by post-exposure? So, ladies and gentlemen, when I say post-exposure, the idea is already you're exposed to HIV. Now you want to prevent it from multiplying in the body. So, if you do this right now, then you may not develop HIV. Let's say I got a needle stick injury, HIV came in my body. If I quickly start the HIV treatment, then I will not develop HIV. All right. Start it earliest possible, maximum within 3 days. Maximum is 3 days. The earlier you start, the better. And you give this for 28 days. The drugs are HIV limited. Mnemonic is this HIV limited, which I told you. Same drugs for prevention, same drug for the treatment. The only difference is this will be lifelong. This will be lifelong. Okay, is that clear to all of you? Next is this. Imagine mother to child transmission. Mother is having HIV. I don't want this to come in the children, right? So how can I do that? First, check if the mother is already taking treatment or not. If mother is on the treatment, good news. Virus is already less in the body, less chances of transmission. I will only give you nevirapine as the drug of choice. All right. And this is given for 6 weeks to baby. Next, second situation, mom is not on drugs. Mom is not taking the drugs. Okay. Here there is some misprint. Please correct. I told you in the class also. We give two drugs, nevirapine plus zidovudine. If mother is not taking treatment, more risk is there. More drugs are given. Nevirapine plus zidovudine. Now you must get something loud and clear in this. What is this? Let's check. If mother is not breastfeeding, okay, not breastfeeding, then no problem. You can just give this drugs for 6 weeks because risk is less. But if the mother is breastfeeding, Logically, the risk of this disease will be higher, so we have to give it for 12 weeks. Okay, so if the mother is breastfeeding, then 12 weeks. If the mother is not breastfeeding the baby, then it is 6 weeks. Done, ho gaya, boss? Then I told you some drugs of this guy, that is HIV, may work in the hepatitis B. So tell me the drugs. Tell me the drugs are those drugs that can be useful in both HIV as well as hepatitis B. Next is malaria. So if a foreigner is coming to India, they need to take 2 doses in their country. Then throughout their stay in India, they should be taking this medicine. Then after they go back, they should take the medicine for 4 weeks. Now this depends on how long they're going to stay in India. If they're staying in India for less than 6 weeks, it's called short-term stay, where we give doxycycline daily. And if they're staying for more than 6 weeks, then I'm going to give a drug called mefloquine once a week. This is about them foreign. Now we'll focus on treatment. Now you must remember that if you're talking about Vivax, we need to give this drug. Very cool fact. Do you remember this mnemonic? You have written in the notes. Very cool fact. Especially Neil. I told you Northeast. The treatment given is AL. NEAL. Northeast. It is AL. So that you will cover in PSM also, etc. I'm sure you have already known this. So what is the mnemonic? Very cool. Vivax, chloroquine, falciparum, ACT. Done. Now this is for treating the malaria disease itself. Right? Symptoms you can control. Now some extras. What do you mean by extra? If you see Vivax, it can come back again because it leaves some extra stage in the liver called hypnozoite. To kill the hypnozoite, we give a drug called primaquine for 14 days. Okay, so in Vivax, we give chloroquine. All these treatments are for 3 days. All these things are for 3 days. I am saying apart from 3 days of chloroquine, you need to give what? 14 days of primaquine. This is for what purpose? To prevent the relapse. This is only given if it is Vivax. But in falciparum, primaquine is only given on day 2. Okay, primaquine is given on day 2. 1 dose, only single dose. Okay, it's a single dose that is given. Primaquine is given for 14 days in Vivax, but in falciparum, it is only given on day 2. Primaquine cannot be given in pregnancy. Please remember, it is teratogenic. So you cannot give this drug in pregnancy. Now that I said this, if you talk about pregnancy, if it's Vivax, only give chloroquine, don't give primaquine. If it is falciparum, again, don't give primaquine. First trimester, give something called quinine. Second and third trimester, you can go for a medicine that is called as ACT. Okay. Next, now that we learned this, please remember that there are two worms, trematodes and cestodes. These are basically the flatworms. Okay, flatworms. So you must remember for the flatworms, the drug to be given is praziquantel. Okay, praziquantel. So this is what you need to know here. Next, just Razi means if you agree. Na? In Hindi, what do you say? Razi means if you agree on something. So if somebody is ready to give you their flat, please yaad rakho, flatworms, praziquantel. Roundworms, nematodes, we give albendazole. There are exceptions that are written there that you need to read. Okay, this is it. Whole of the worms are treated by two drugs more or less. One is praziquantel and albendazole. Like in your parasitology, the worms are treated like this. Okay. Now, since we have said this, antifungals may what I want you to know. One is your cortisol drugs. Okay, these four specifically. Keep an eye on cryptococcal meningitis. This recently came in INI-SET. Exactly what is written in the note here. They asked this. Combination of amphotericin B plus flucytosine. They will ask this in your exam also. So they may repeat this question, I'm telling you. Now, amphotericin B, it's usually used in serious infection. Treatment of something severe, we are going to go for amphotericin B. So I just told you it's used in cryptococcal meningitis. It's written here, mucormycosis, etc. Okay, that's about it. Now that we learned this, okay. Next is if you talk about the general antibiotics, please read the classification who comes in cell membrane inhibitor. Heading है पूरा proper, you should know the classification. Cell membrane inhibitor, drugs like daptomycin. Then you have cell wall inhibitors. Cell wall inhibitors, you got drugs like penicillin, cephalosporin, vancomycin, etc. Then we got protein synthesis inhibitor, the mnemonic I might have given you. You can check this later. Buy at 30, sell at 50. That's the mnemonic you wrote. Memorize it like this. Then lastly, nucleic acid. Nucleic acid means DNA and RNA inhibitor. DNA inhibitor like floxacin, RNA R for R, rifampicin. ये classification इनका जो rough outline I have given you right now. Read this classification properly, then revise their side effects. For their uses, you can see mnemonics are given over there. Still, what I will do, the important infections, what they may ask. All right, it's not so easy thing because it's a very huge topic, so many microbes are there. But for important things, what they may ask, I will make a small PDF and I'll share it, after few days or so. Okay, तो वो उसमें होंगे, like for example, if they ask you suddenly what is the treatment for listeria? अब ये क्या है sir? You have to know your microbiology also. Along with that, you have to memorize. This is a difficult part for every doctor. Practicing doctors also, antibiotics is not an easy thing, right? So I'll make a list. Listeria ampicillin is preferred. Like that, I'll make a list and I'll share it later. All right. So don't worry. I'll share it in the missed group only. I will tell them to upload. So officially, I'll send that. Clear? So hoping that you're already in those groups. Next is something called gastrointestinal system, GIT. This is where you got your main thing, that is peptic ulcer disease. Okay. So when you talk about the peptic ulcer, what is something that they may end up asking? See, what do you do when it comes to peptic ulcer? Our aim is to reduce the acid first. That is the best thing to do because acid touching, right? When the acid touches your inner layer, it causes pain. So first you reduce the acid itself. That's my aim in the treatment. Is that understood? So for that, I need to give you PPIs, etc. Now, what they will usually ask in this is, how do you treat H. pylori? Remember, I told you triple regimen and quadruple regimen. What is triple regimen? 2 antibiotics plus 1 PPI, right? 2 antibiotics plus 1 PPI. So there are regimens called OCA or OCM. O for omeprazole, C for clarithromycin, A for amoxicillin, or M for metronidazole. Now, which antibiotic is seen in both of them? Clarithromycin. Imagine there is a person who's not responding to clarithromycin, he is resistant. Obviously, if clarithromycin is not working, I can't give you triple regimen. I need to give you something called quadruple. What is quadruple? OBMT. What is OBMT? O for omeprazole, M for metronidazole. So what is B? Bismuth. B is the bismuth and T for tetracycline. T for tetracycline. Tetra is given in quadra. Tetra is given in quadra. Okay. So one question is this, they will ask you. ठीक है. Next in this topic, they will ask is antiemetics. So make sure you know about this antiemetics also. Morning sickness, meaning pregnancy induced vomiting, we need to give doxylamine plus pyridoxine, right? Doxylamine plus pyridoxine. All right. Next. Next, second thing, motion sickness. Motion sickness. If you talk about motion sickness, this is where we already learned scopolamine or hyoscine can be used. But even some antihistaminics like promethazine can be used. Drug of choice is this only. Okay, drug of choice is this only. Next is chemo-induced nausea vomiting. So in this situation, chemo-induced nausea vomiting, we can divide it into two words, early onset and late onset. Early onset, if we talk about, okay, early onset, if we talk about, so you must keep an idea that we are going to give something called citrons. Late onset, I'm going to give you drugs called pitants. Early onset, it is citron. Late onset, it is something known as pitants. So I gave you the mnemonic also. If you come late to the class, you will get pitai. Pitai means beatings. So what is early late? Less than 1 day is called early. More than 1 day is called as late onset. Okay. So that will be the high yield things in this topic. Okay. Next is you'll see one more topic of GIT in the 25 important I've discussed. Something the drugs like domperidone and metoclopramide. I've made a good question on that, so you can learn it from the question how it will come. Last topic is your asthma. See, what is happening in asthma? You all know it's a hypersensitivity disease leading to bronchoconstriction. What happens in this? It's a type 1 hypersensitivity. So in type 1, there is somebody called IgE that binds to mast cell. Mast cell releases certain things like leukotrienes, which causes bronchoconstriction. So what I will do, I can control everything from the top itself by giving drugs called steroids. Okay, I can give you steroids. They are the mainstay of the treatment here. Next, second thing, symptomatic relief will be by bronchodilator. So combination of steroids plus bronchodilator is given in the treatment here. Next, nowadays, what they do, they divide asthma into something called phenotypes. Okay, they divide asthma into what we call as phenotypes. What is meant by phenotypes? Sarji, phenotype simply means the types of asthma. Ab you will be thinking, what are the types of asthma? Sir, some people will have too much of eosinophils. That's called eosinophilic asthma, like that. So if eosinophils are more, then I need to give you something. Allergic asthma, I need to block Ig in that. So like that, we'll be giving different drugs. So what are the drugs which are bronchodilators? Sabalaba, salbutamol, salmeterol, Samalama. What is Samalama? Ipratropium, tiotropium, etc. So all these things, right? Next, theophylline, methylxanthine. One more bronchodilator is called as what's a theophylline. Okay. Next, now that we have said this drug is a very narrow spectrum drug called theophylline. So it's not a good idea to give that drug. Theophylline is a narrow spectrum drug. So now that we have said that, it may cause arrhythmias, etc. Next is this list. I gave you IgE blocker and IL-5 blockers. If you remember, I told you this. Coming to this, steroids. Okay, coming to steroids. I already told you the names Xyluton, Lucast in the beginning. That's why I'm not reading them again. Steroids may, what they may usually ask is this. Okay, keep an eye. Cyclosinide, etc. it will not cause this side effect that you see here. All steroids cause this side effect, oropharyngeal candidiasis. Oropharyngeal candidiasis. Cyclosonide will not cause that side effect. Why? Because it's an inactive drug, it's a prodrug. So when I put the cyclosonide in my mouth, it is a prodrug, it's not active, it's not causing any effect. So it will not cause effect also, side effect also. This drug gets active only when it reaches the lungs. That's where it is having that advantage. Other drugs, the moment they fall in the mouth, because they're already active drugs, they will reduce immunity, causing this candida. You can see how to prevent it and to treat it. Okay. Now, this also I explained to you earlier, the GINA guidelines. What do you need to know? Pretty straightforward, simple. First, the treatment is going to be ICS plus bronchodilator like formoterol because it's long acting. ICS will be low dose. Steroids will be low dose. Let's say this is not enough. Then what do you do next? Next, what you're going to do, same ICS. Okay, same ICS plus formoterol, but you increase the dose to medium dose. Next, if this is also not working, then what do you do? Increase the dose of ICS, obviously. You will go for high dose of ICS plus formoterol as usual. And if you need, if right now, then you might need to give a specific drug for the phenotype. Okay, specific drug for the phenotype. Now, I'm going to give you a list. This is based on updates. Okay. If there are some changes compared to the previous notes, etc., please follow this instruction given right now. Okay. I told you if something comes up or anything, I will be telling you guys. Anyway, now imagine if they're saying something called persistent asthma. Persistent asthma due to any type. Okay. Persistent asthma due to any type. What is the drug to be given in the treatment? ICS, inhalational steroids. This is the answer you should give. If they say aspirin induced asthma, then what do you answer? The drugs called as LTRA, leukotriene receptor antagonist, called as montelukast, etc. Okay, you can give Lucas drugs. Lucas are what? Leukotriene receptor antagonist. This is for aspirin induced. Next, if you talk about exercise induced asthma, then we can give two things here. Either you can give Saba before exercise, short acting, as long as you need to exercise 2-3 hours, you can have this, right? Or you can go for LTRA also. Leukotriene receptor blocker also, they can be used. Next, if it is allergy means you should go for omalizumab because IgE is the antibody for allergy. And what is this drug? It's a IgE blocker. So omalizumab. Okay. Eosinophilic asthma. Eosinophilic asthma means you have to go with IL-5 blockers. IL-5 blockers are mepolizumab. Okay, mepolizumab, benralizumab. These names I told you here only, na, IL-5 blockers. IL-5 blockers are these. It's already written. Okay, I'm just consolidating these things here for you once again. Okay, so that's all that you see here. And if it is, let's say, severe, uncontrolled asthma, okay, severe uncontrolled asthma, then I'm going to add something like LAMA. Add LAMA to the main treatment. What is LAMA? Topium drugs, right? Tiotropium like drugs. tropium drugs are added in the treatment of this. Okay. So this is it. I'm saying just in case if they go even into the phenotypes, you should be knowing this specific treatments for specific things. Okay. So by this, our quick review of pharmacology is over, my friends. So one piece of advice, once again, I'm reminding you, do this video right away, do the 25 important ones. So the important information will be consolidated in your brain. One time reading is not enough right now. Of course, you need to read this again, right? So either every day you take this and read 20 minutes, one small chapter. Like you can see like this. Once you know the chapter, it doesn't take as much time. It may take little more time. In case you're not thorough, 30 minutes, give that 30 minutes every day in the morning or something. Okay. Then after doing the 25 important videos at a faster speed, 2x speed, then you may come back, read the notes on your own. Then in the reading aspect also, first quick review, you will do only drugs of choices. Second review, side effects. Then anyway, you're done. If you have energy left, then you can go for a third quick review for everything together. We have to work hard, then only we achieve something. If you do this, I can tell you the feeling that you are having so far that I don't know anything in pharma, at least you will get 70% easy. Okay, that's all I can tell you, my friends. So see you soon enough in the test and discussion. All right, take care, everyone. Best wishes for your preparation right now.